Hello, doctors. Please, are we still there?
Yes, we are.
Yes, sir.
I'm so sorry
Yes,
about
we are.
the. I'm so sorry about that. I had some technical issues with the recording. Okay. Um. Yeah. So I think I was trying to show us the image, and we've answered the question. Um. So this is seborrheic dermatitis. Is that very correct? Uh. So the second question: an otherwise healthy 15-year-old girl is brought to the physician for evaluation of severe acne that involves her face, her chest, and back. It has not improved with her current therapy of oral cephalexin and a topical combination of benzoyl peroxide and adapalene. What kind of medication is adapalene? Anybody remembers?
Vitamin A.
Vitamin A analog, yeah. She's sexually active with one partner and they use condoms consistently. Facial scarring with numerous comedones are present with sebaceous skin lesions on her face, chest, and back. Before initiating treatment, which of following is the most appropriate next step? Anybody?
Perform HCG.
Perform
Check
BCG to rule out
pregnancy
pregnancy
Why? Why?
Yeah.
Why?
because
Because
we're
it's
still at the
teratogenic.
retinoid.
because we want to
Teratogenic.
initiate isotretinoin,
Mm-hmm.
which is
But
teratogenic,
that's correct. But why are we initiating isotretinoin here?
because she has severe acne, nodulocystic
I
type,
think
I guess.
nodulocystic, yeah.
Yes. So
And
actually,
there's
the question did
scarring
not
as
state
well.
that she's having it, but the question said facial scarring. So that is in keeping with the nodulocystic one. I know we know it, so I just want to point it out to us. Like sometimes we can see scarring too. You know, scarring also means that it's very bad. You know, scarring, nodulocystic, all of them together like that. Okay, that's very good. A 64-year-old man with hypertension comes to the physician because of a 5-month history of facial rash. He occasionally feels burning or stinging over the affected area. His only medication is lisinopril. A photograph of the patient rash is shown. Which of the following most likely contributed to the development of patient's condition? So let me look for the rash. Okay, so that is the rash. What do we think? We have seen the rash. Let me go back. So sorry about this. Okay, going back to the question. So although the question doesn't have much detail, but let's just try. 67-year-old man with hypertension comes to the physician because of 5 months history of a facial rash. No, that should not be the question. That should not
Yeah.
be. He occasionally feels burning over the affected area, and his medications are not pretty. I think I must have missed it up somewhere. Let me see because they're saying a facial rash. Okay, this is a rash. Is this a rash? Am I sure?
Yeah.
Yes, it looks like it.
Sorry. Okay. Okay, yeah, that is a rash. Thank you very much. So that is a rash. And they told us that it has been on for 5 months. He feels occasional burning or stinging over the area. The only medication is lisinopril. The photograph of the rash is shown. Which of following is most likely contribution to the development of this lesion? Anybody?
I'll go for alcohol
Alcohol
consumption
consumption.
because it is
Processing.
acne rosacea
Exactly. So that's the research. So
and
sorry
prominent
about
on the cheek.
so sorry about
Sorry, I
the
didn't get that. I didn't get that. What did you say?
So the diagnosis is rosacea. Like we can see the lesion, right? We can see the rash, the weight,
Yes.
the person's, looks like rosacea. You can see the flushing over the nose everywhere. You can see the papules, old man. So it's likely to be rosacea. So that's why we went for alcohol consumption. Okay. So number 3, a 15-year-old boy comes to the physician because of skin changes on his face, the chest, the back over the past 1 year. Treatment with over-the-counter benzoyl peroxide has been ineffective. Physical examination shows numerous open comedones, inflammatory papules, pustules on the face, chest, and back. Which of the following is the most likely underlying mechanism of this patient's condition? Anybody?
Increased levels of
Increase
androgen.
levels of androgen level.
Okay. So why not hyperkeratinization of the hair follicles? Which one is that going to
Mm.
be? So I did not really lay emphasis on it, but I mentioned that keratosis pilaris, right?
Oh yes.
So that's going to be keratosis pilaris. So, but that is not keratosis pilaris. So this is likely to be acne. So, increased level of androgens is going to be correct. Okay. A 48-year-old man comes to the physician for evaluation of an intensely pruritic skin rash on his arms and leg for 12 hours. 2 days ago, he returned from annual camping with his son. The patient has no medication. Photograph of the skin lesion on his left hand is shown. Activation of this, which of the following cell type is most likely the cause of the skin finding? So I think that was the
C cells. Yeah, that's the
exactly.
T-cells.
poison ivy.
Yeah,
C
that's
cells.
the poison ivy. So that's going to be T cells because what type of
Just
hypersensitivity?
Type
type
4.
4.
Type 4. Very
Type
good.
4.
Good job. Good job. Good job. A 34-year-old man comes to the physician for evaluation of a rash on the elbows for several months. A biopsy of the affected area shows a thinned stratum granulosum as well as retained nuclear and spongiatic clusters of neutrophils in the stratum corneum. This patient's skin findings are most likely associated with the following conditions. So seronegative.
Hashimototheritis.
What's the diagnosis? The first thing is to have a diagnosis. What is this diagnosis?
This is
Psoriasis.
Looks like
because it's
psoriasis.
on
Psoriasis.
the elbows, and they've talked about the retained nuclei, which is the
Yes.
parakeratitis.
So this is what? Psoriasis, right?
No,
Correct.
psoriasis. Yes.
So why are we picking Hashimoto?
Seronegative.
Isn't it seronegative
No, it should be a
property? A.
So
It's A.
negative spondylitis, no catch. No catch at all.
spondylitis.
What's hypersensitivity to gladine? What is that?
Celiac.
That's what the
Celiac.
celiac disease. Celiac.
So we are going to talk about the one that affects celiac very soon. Infections with hepatitis C, yeah, very soon too. Hashimoto thyroiditis will be. So which condition will make us pick Hashimoto thyroiditis?
Vitiligo.
Celiac.
Vitiligo.
Autoimmune like vitiligo.
Good job. Parkinson disease. So which condition can make us pick that?
Seborrheic
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 dermatitis.
dermatitis.
Seborrheic dermatitis. Insulin resistance. So we've not got into that part.
acanthosis nigricans.
Agricultural negligence. Some people already know all the stuff. So that is it. Okay. So moving on to the vascular tumors of the skin. And the first one here I have is angiosarcoma. So angiosarcoma is a very rare malignancy of the blood vessel. It typically affects the endothelial cells of the lymphatics as well as the veins. So it is a very malignant tumor, which is very bad. And it occurs usually in older people that are very old, on the sun exposed areas of maybe the upper chest, for example. So there are three major triggers, if not more than three. The first one I want us to know is that people that are exposed to radiation long term, they can develop angiosarcoma. people that have undergone chronic, sorry, I think I have, I'm so sorry, please 1 minute. Okay, I'm thinking, should I give us like break because we have spent like 12 or 30 minutes? Should we just
Yes,
finish
sir.
Yes,
angiosarcoma?
please. Yes.
Yes, sir.
Okay, so,
Yes, please. Thank you so much. Yes.
okay, so,
Okay.
1 hour break.
please wait.
How many minutes?
Like,
1 hour.
I'm saying that 1 hour, we don't want, you don't want us to finish this
No,
thing.
no, 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 not 1 hour.
So, like,
30 minutes.
Please,
um,
30:45.
30 minutes so we can finish on time.
okay,
30
okay,
minutes.
30:45.
exactly. So,
Can't do to 8 today, I beg.
30 minutes is good.
please, like what I just let us finish the angiosarcoma so that it's going to be like 12:30 my own time, then we'll go for the break.
No
30 minutes break.
problem.
Okay. So, um just like I said, don't forget people exposed to radiation, people that had undergone maxectomy, and you've done like axillary clearance, and there's problem with drainage of the lymph, at that area. So there's going to be ventral lymphedema. So all those things can also irritate the lymphatic vessels, you know, causing angiosarcoma. And that's for the cutaneous angiosarcoma. And what I've mentioned now is what you call the Stewart-Trevet syndrome. So you don't need to remember the name because nobody's going to, unless you just want to be moving stuff. But nobody's going to be asking us like, what's it called? Stewart something syndrome in the exam, you know. But it follows, people with maxectomy developing chronic lymphedema, irritating the lymphatics, and they developing angiosarcoma at the end of the day. So the last form of angiosarcoma that we need to know is also the hepatic angiosarcoma, very commonly tested, and it is associated with the use of vinyl chloride and arsenic. So if they ask you anytime, what are the common risk factors for hepatic angiosarcoma, not cutaneous angiosarcoma, hepatic angiosarcoma, you talk about polyvinyl chloride or arsenic exposure. It's very difficult to treat. So most of the time you have to do like resection and all those things. And it commonly affects the head, the neck, and the breast. Of course, the breast in people that have undergone maxectomy. But people that have it in the head and the neck, most likely maybe they've had exposure to radiation, maybe from oropharyngeal cancers. They can develop angiosarcoma. What does angiosarcoma look like? So most of the time, they have this blue, discoloration of the skin with sometimes hemorrhage, ulcers. It looks very disfiguring. And I just read this thing out. You know, I mean, I think I have too much files on my system. So sorry about this. Mhm. I think probably I'll just have to go online and just show us, what it looks like. Angio, angiosarcoma, cutaneous, angiosarcoma, cutaneous. So we see what it looks like. Are we still with me? Hello? Anyone there? Um, yeah, so I was trying to talk about the angiosarcoma, and we've already emphasized the risk factors for the cutaneous angiosarcoma as well as hepatic angiosarcoma. Please don't forget those risk factors. That's very, very important. They are very, very important, please. And I was also trying to show us an image of the angiosarcoma, what it looks like. So this is angiosarcoma on somebody's head. So don't forget the cutaneous form, you usually see it on the head and neck. and also involving the breast for people with the Trevor syndrome. So this is a tumor. You can see the
When
hemorrhage.
we're not seeing
Doc,
your
we can't see your screen, sir.
Sorry, I forgot to share my screen. So sorry about that.
don't forget to record it.
Yeah, thank you for reminding me. I'm already recording. Thank you very much. So here is the picture. Can we see the picture now?
Yes.
So this is the angiosarcoma on the head of one old man. We can see the areas of bleeding. We can see the bluish, reddish discoloration. This is what we expect. So the history is going to guide us actually. So that's that about angiosarcoma. Don't forget the distribution, the head and neck, and the breast. Don't forget radiation, chronic sun exposure, as well as chronic lymphedema from mastectomy. Those are the common risk factors. So moving on to bacillary angiomatosis. So bacillary angiomatosis is one of those benign um, tumors. Let me call it like a tumor affecting the capillary. And what you typically see is just like reddish papules. This condition is very common in people that are immunosuppressed, particularly from HIV. So they can develop bacillary angiomatosis, and it's very common in people with AIDS, just like I said, with CD4 count less than 100. So people with CD4 count less than 100 having skin papules that looks like this reddish, purple like this in immunosuppressed patient, think of bacillary angiomatosis. Think of bacillary angiomatosis. So it's being caused by the Bartonella infections like Bartonella and Celi, and it's very, very similar to Kaposi sarcoma. Don't forget, Kaposi sarcoma too occurs in people with HIV, AIDS particularly, and the only way you can differentiate them histologically is by analyzing the infiltrate. So people with bacillary angiomatosis, don't forget, it's caused by Bartonella infection. They are going to have a neutrophilic infiltrate. Neutrophilic infiltrate. While those with Kaposi sarcoma are going to have a lymphocytic infiltrate, because Kaposi sarcoma is caused by the human herpes virus type 8. So that's a virus. So, and you have lymphocytic predominance in viral infection. Why for bacteria it's usually neutrophilic. So don't forget that. Don't forget that. I'm going to show us a picture of Kaposi, and we'll be able to differentiate between the two. So moving on to the cherry angioma. So cherry angioma is also a benign tumor affecting the capillary. It's very common in people that are of middle age, like 30 years, 20 years above. One thing about cherry angioma you don't want to forget is that it does not regress. In fact, that is the only thing you'll be looking for in the question. Once you see something that looks like image B, this particular image, not bleeding like the what's it called? The bacillary angiomatosis, but something like, well circumferential and confined like this. And they tell us in the question stem that the thing is increasing in size with age and is not reducing. Just know that individual is having, your cherry angioma. It's a benign proliferation of your capillary beds, and it occurs in people that are middle age, like 20 years above. It's not something you see in small children. So, and it does not regress with age. That's the clinch. In fact, that if that is the only thing you remember about cherry angioma, you are okay. I can assure you. Then the next is the glomus tumor. So, beneath the toes and the fingernails, beneath the beds that are there, you have a smooth muscle. So you call that the globus body. This smooth muscle contains some arteriovenous connections, and they have a thermoregulatory function. What they do is that they sense, the temperature, of the environment, and if it's cold, there's a response. If it's hot, there's a response. So if it's cold, they can undergo like constriction. And the reason is that they want to limit blood flow to that area, to the extremities. Because if it's cold, you don't want to dissipate further heat to the environment. So you limit the blood flow to the extremities so that you conserve your heat to the core body organs. Why if it's very hot, they undergo like vasodilation, so you can have more blood flow to the extremities to dissipate heat to the environment. So they have a thermoregulatory function. But sometimes they can undergo some, tumoric changes. And when they, become like a tumor, it appears very painful. And you see them having this red-blue coloration. So it makes sense for us to connect the reason why it has a red-blue color, because it's made up of arteries and veins. So the artery is going to be red, the venous part is going to be blue. So, and it's very painful. So somebody having painful red-blue tumor beneath the fingernails, you know what they are talking about is a what? A glomus tumor. Very straightforward. The next is Kaposi sarcoma. So, Kaposi sarcoma is another tumor, that's usually like malignant most of the time, and it affects the endothelial cells of the vessels. It's very common in people that have it, particularly when the CD4 count is less than 200. So when the CD4 count is like less than 500, they can have Kaposi, but the Kaposi they have is a cutaneous form of Kaposi sarcoma. When it's getting to less than 200, they start having the systemic form, in which they are going to be forming the lesions in the lungs, in the GIT, and they can be presented with hematemesis, they can be presented with hematochezia, hemoptysis, depending on where exactly the lesion is at that time. So once you say Kaposi, think of HIV/AIDS, think of the human herpes virus type 8. That is the Kaposi sarcoma virus. Very, very important. It can also occur in people that have undergone organ transplants, because at that point, they are immunosuppressed. So everything about Kaposi sarcoma links with immunosuppression. You cannot forget that. So it is associated with HIV, it is associated with HHV type 8, organ transplantation, and other causes of immunosuppression. So when you do your biopsy, what are you going to see? Lymphocytic infiltrate. Don't forget, it's caused by a virus, human herpes virus type 8. So it's going to be lymphocytic. Unlike bacillary angiomatosis, that's going to be what? Neutrophilic. Also, when you do your biopsy, you are going to find spindle cells. Spindle cells describing the endothelial cells that are proliferating. So they appear spindle on histology. Let me show us what it looks like. I think I have an image here, because you cannot go for your exam. You don't know how Kaposi sarcoma looks like. So unlike bacillary angiomatosis, they are usually reddish in color. Kaposi sarcoma can be red, but most of the time they are purplish. So they look like something like this. Purplish, violaceous color. Once you see the question stem describing something purplish, violaceous with a mix of red, you know that this is likely to be Kaposi. This is the way they look like, like bleeding points everywhere, like as if you're having like hematoma collection. It's due to the hyperproliferation of the endothelial cells. When the endothelial cells are proliferating, they become weak and they are leaky. So you can have blood extravasating into the tissues, creating this lesion. This is exactly how Kaposi sarcoma looks like. So you can have this exact lesion occurring in the lungs, in the GIT, and that is a systemic form. So that talks about a lower, level, a very high level of immunosuppression by the time it's getting to the systemic aspect. Kaposi sarcoma. Then the next is pyogenic granuloma. Now, what you just need to look out for in pyogenic granuloma is that you are going to be seeing a lesion, capillary proliferation, forming an hemangioma that is polypoid in shape. So polypoid, like looking like a polyp, exactly, polyp, raised and kind of polypy, if there's a word like that, in shape. And they will tell you that it bleeds easily to touch. They touch it like this, is already bleeding. Classic for pyogenic granuloma. So it's very common in people that are pregnant or people that, undergone trauma. Maybe you had trauma to the part of your skin, particularly the upper extremity like the face, they can develop, or the lips, they can develop this pyogenic granuloma. But it's very common in people that are pregnant. So they can easily ulcerate and bleed. That is the stuff you have to hold on to. It's going to help you a lot by the time you start solving questions. Pyogenic granuloma. Trauma, pregnancy, easy bleed, polypoid in shape. The last that we have here is the infantile hemangioma, otherwise known as the strawberry hemangioma. So we already talked about the cherry hemangioma. It's like we are talking about fruit. The cherry hemangioma. Now we are talking about the strawberry or the infantile hemangioma. They will tell you that they are seeing this kind of lesion, this growth in a child that's just maybe 1 year or a few months old. That is infantile hemangioma. You don't need to worry, because the next thing they will ask you is that what is going to be the fate of this lesion? Reassurance, biopsy, excision, laser ablation, blah blah. Most of the time, this guy is going to regress by 5 to 8 years. Most of the time, it's involute by 1 year, but you can be rest assured that by 5 to 8 years, it's going to go completely. So they start involuting by 1 year, and by 5 to 8 years, they disappear. So they appear within the first few weeks of life. They start growing, but later they will start regressing by 1 year, and by 5 to 8 years, they are gone. Your cherry angioma will not regress. Your strawberry or your infantile hemangioma will what? They will regress. By the time we come for step 2, we'll start talking more about why you might need to give medications to people with infantile hemangioma. But for the sake of our step 1, we don't need that. So that is that about the vascular lesions. Moving on to the skin infections. This is real dermatology now. You don't want to forget the bacterial infections. They are high yield. I can assure you. I can assure you with anything. There's no way you miss it. They will test you on this, and it is very simple. One of them is going to come out. Everybody gets it. So I want us to pay good attention here and get the gist once and for all. The first one is impetigo. Impetigo is commonly tested, and it's majorly a skin infection confined to the superficial epidermis. The problem that is happening is just within the superficial epidermis. That is it. What are the 2 organisms you don't want to forget for impetigo? Staph aureus and gas. What I usually call gas. Group A, streptococcus. Group A, streptococcus. An example of the group A streptococcus is what? Strep pyogenes. So sometimes I can say gas, sometimes I can mention strep pyogenes, so they mean the same thing. But what is peculiar to these organisms? If the impetigo is bullous, that is, you are seeing bullae, just go and shade Staph aureus and move. Just go and shade Staph aureus and move. If it's non-bullous, okay, you can now consider strep pyogen. But all the cases of bullous impetigo is caused by Staph aureus. Staph aureus is a very notorious guy. Causes a lot of problems in dermatology. I also want to say that impetigo is very contagious, but all these things I've been saying now will not allow us to identify this lesion. Please, what do we need to see to identify impetigo? Now, what you need to look out for is just I don't have the image here. I think I attached it here. The crusting, just like I said. Once you see a child having crusts, yellowish, dry exudate on their face, just go and pick impetigo. Sometimes you can see like bullae surrounding it. Okay, you know that this is bullous impetigo. If you don't see any bullae there, you know that is a non-bullous impetigo. and that you are going to be picking your gas. But if you are saying bulle in addition to the crusting, that is what? Your bullous impetigo caused by what? Staph aureus. So Staph aureus elaborates one exfoliative toxin type A, which is responsible for most of these problems. Okay, so don't forget they are very, very contagious. So most of the time, small children, they get it from school. When they are playing with themselves, they can easily contact it. So impetigo. The next one is erysipelas. Now, erysipelas is now coming down. Impetigo is epidermis. Erysipelas is now the upper dermis and the lymphatics. It hasn't gotten to the lower dermis and the subcutaneous tissue because that's going to be something else. And many people confuse erysipelas with cellulitis, but it is very simple. You don't need to stress yourself. Once you just figure out what you need to know, forget about it. You just be smashing. What you need to know for erysipelas is that the border of that lesion is going to be well demarcated. In fact, see, once you see that you can delineate the border, forget about it. Just tell them that I can tell you 100% that what you are dealing with is erysipelas. If you look at lesion A, this is the impetigo. We can see the yellow crusting. Image B is also talking about impetigo. We can see the bullous lesion here. So this is most likely to be caused by Staph aureus. You can see the yellowish, exudate that is well crusted over it. Image C is the one talking about the erysipelas. We can see that this lesion is well demarcated. I can, put a marker around it. And you are going to be seeing the cardinal signs of inflammation. It's going to be tender. It's going to be painful. It's going to be swollen. That is the erysipelas for you because there is an infection affecting the dermis, the upper part of the dermis. And what is the implicating organism? Cannot forget it. Gas is the implicating organism for erysipelas. Your group A strep, your group A strep, which is your strep pyogen, it is implicated in erysipelas due to infection of your lymphatics and your upper dermis. Now, the infection can go deeper than this, and it will go to the lower dermis, go to the subcutaneous tissue, and it will appear very tender, very swollen. But you now notice that the margin is no longer well demarcated, like in erysipelas. Your diagnosis is changing to cellulitis. That is the way it works. You can never delineate the border of cellulitis. That's a very key difference. The margin is not well delineated. And one of the most notorious causal infection for cellulitis is your Staph aureus. Your gas too can cause it. So it usually occurs when there's a previous trauma, when there's stasis, when there is tinnial infection, superimposed infection. Think of anything can be a risk factor for cellulitis. But know that cellulitis is very, very common in the extremity. Very, very common in the extremity. So once you are looking at the question, there's a tender, swollen, red lesion. And you ask yourself, where is this lesion in the extremity? Okay, this could be cellulitis. You try to look at the history. Any risk factor? Immunosuppression, diabetes, obesity, stasis, dermatitis, trauma to that leg, just to be sure of what you are dealing with. And by the time you do your culture, you can identify whatever organism. But most of the time, it's going to be Staph aureus. And it can be also, your gas sometimes. Now, the next is the abscess. Abscess, like we all know, is just like pus confined within a cavity. That's just abscess. You just have like a cavity filled with pus. That is it. And the implicating organism in most cases of abscess is still Staph aureus. It is as basic as that. You don't need to complicate it. Staph aureus. The next is necrotizing fasciitis. You cannot joke with necrotizing fasciitis. I want to tell us that necrotizing fasciitis is a surgical emergency. If an individual presents with features of necrotizing fasciitis, you have to rush the person and do a very fast debridement. Or else the person is going to die. Going to become septic, the person will die. So it is surgical emergency because you need to debride, place on broad spectrum antibiotic and resuscitate. But what is necrotizing fasciitis all about? This is just associated with infection, of the fascia, the superficial fascia, the deep fascia of the tissue. So that means we are not talking about the dermis anymore. We're not talking about the epidermis. It has gone beyond all those areas. It has eaten deep into the fascia, and the fascia is now becoming necrotic. But what are you going to see in the question that is going to heighten your suspicion for necrotizing fasciitis? They will tell you my number one stuff. That is my joker. That anywhere I go, it is my joker. I've just tell my consultant, I expect crepitus, because most of the common cause of necrotizing fasciitis involves anaerobic bacteria. And by the time we come back to our microbiology discussion, I'm going to be telling us about some of those infections and what is peculiar to them. So anaerobes, they undergo all this fermentation and they produce a lot of gas like methane and CO2. So the CO2 methane is going to be tracking along the tissue planes, generating this crepitus sound. So crepitus sounds as if you are stepping on dry leaves. Just picture as if you are stepping on dry leaves. How it sounds, crepitus. Once you have that, you know that this individual is already having necrotizing fasciitis due to, anaerobic infection. What else are you going to see? What else? You are going to notice a discoloration of the skin. Is going to appear black, it can appear blue, with bullous lesion developing. So I think I have an image. So you have bullous lesion like this. We can see all these areas of discoloration. This one is even appearing like red. Most of the time you see black, dark color. You see the bullous lesion. If I touch this lesion now, the pain is going to be out of proportion to what I expect. They have pain out of proportion to the manifestation. They have bullous lesion. By the time you palpate, you are going to be, feeling for crepitus. Sometimes it can be foul smelling as well, and sometimes it can even disseminate and the person might be having confusion, altered sensorium, and the likes. But don't forget, they are going to have the skin necrosis and the bullous lesion, which is going to impact this volaceous color. They are going to appear blackish or purplish. Don't forget the crepitus, very, very important stuff. Don't forget the pain, which is out of proportion. And don't forget that the implicating organism, in most of the cases, anaerobes, Bacteroides, your Streptococcal, Clostridium, and sometimes strepiogens. So an individual having like fonia gangrene, we remember that in our urologic rotation. Fonia's gangrene is very similar to, just like necrotizing fasciitis of the perineum. Very bad stuff. Flesh-eating bacteria that are eating all the facial, producing a lot of notorious gases, releasing toxin that is destroying the tissues, and can cause death if not appropriately treated. So don't forget, it's a surgical emergency and you need to debride. You debride, remove all those necrotic tissues, and place on fluids as well as broad spectrum antibiotics. The last here is what? The staphylococcal scarlet skin syndrome, SSSS. So this guy is caused by Staphylococcus aureus, and it is very, very common in newborns or individuals with renal insufficiency. So if an adult is having SSS, and the next thing I want to ask myself, is it that this guy is having renal insufficiency, or what could be predisposing to this staphylococcal scarlet skin? Now, what is the presentation of somebody with the SSS? To have an image, see. Okay, so this is the necrotizing fasciitis. This is a SSS. So that child, I want to say child because I want us to have it at the back of our mind that most of the time it's common in children, in newborns. So usually less than 5 years. So newborns and children rather, less than 5 years, they usually have this guy, staphylococcal scarlet skin. And you see the history, showing a child that has fever that has a rash. Now, what they are going to tell you about the rash is that they will tell us that the rash is desquamating. It means that you can easily be peeling off that skin. The skin is sloughing off. Desquamating lesion, fever, and there is no mucosal involved. You see, that is the next thing you are looking for. Once you are seeing a rash, desquamating rash, fever, okay. Let me go and check the mucosa, because that changes the diagnosis totally. In Staphylococcus scarlet skin syndrome, there is no involvement of the mucosa, but they will try to confuse you by telling you that there's perioral crusting. Please, my people, perioral crusting does not mean that there's affectation of the oral mucosa. It is peri, not involving the mouth. So, fever, desquamating rash with perioral crusting is classic for Staphylococcus scarlet skin syndrome. It can be a complication of bullous impetigo. It could be that this child started with bullous impetigo, which progressed to SSS. So many things can cause it. They will tell you that during the examination, manual stroking of the skin leads to further separation of the epidermis. That is what we call the Nikoski sign. Nikoski sign. Staphylococcus scarlet skin syndrome is one of those pathology where the Nikoski sign is positive. Now, why is all this thing happening? It is because Staphylococcus aureus produce a particular toxin that we call the exotoxin A. The exotoxin A. Now, what is this exotoxin A going to do? Exotoxin A is going to attack the desmoglein 1 and 3. And we remember what the desmoglein 1 and 3 does. They help to form, the desmosomal connection between the keratinocytes, right? Particularly the ones attaching the stratum granulosum, And once you have this exfoliative toxin, being involved, it destroys those desmosomal connections by affecting the desmoglein 1 and 3 action, and you begin to have separation of the epidermal cells, the keratinocytes within the stratum corneum, the stratum granulosum. So that is why you have easy sloughing of the skin. You want to compare it with toxic epidermal necrolysis or our Steven-Johnson syndrome. They can also present like this, but their own separation is going to happen at the what? The epidermal dermal junction, not within the stratum granulosum. Okay. I don't know if I have any question here. I'm not sure I have any question here.
Boss, please question.
Okay, I'm with you, sir.
Yes, sir. For the impetigo, I just wanted to understand which toxin is affected there as well too.
Yeah, the exfoliative toxin also is involved in causing the impetigo too from staph aureus.
Okay.
Yes. So, but
So does it affect the desmoglobin as well?
does it what?
Does it also affect the desmoglin?
Desmosomes. No. It doesn't actually affect the
Oh,
desmosome. It just affects something else, which I don't know. But it's
okay.
not through the desmosome. The one that is through the desmosome is the SSS. So,
Yes. All right.
but I
Thank you.
know that exfoliative toxin also plays a role in impetigo. Yeah.
All right. Thank you.
So, moving on to the viruses. So, the first we have here is the herpes. So, we are not going to be talking too much about them because it's going to be discussed in microbiology. So, we have the herpes virus type, the simplex virus type 1 and 2. We have a lot of the herpes, human herpes 1 to 8, but here we are just talking about the 1 and 2. And we know that they can cause herpes labialis. Both of them can cause herpes labialis. They can cause herpes genitalis, in which the individual is going to be having painful ulcers, in the genitals. Once you are seeing painful ulcers in the genital, you want to think about herpes genitalis. They can have hepatic weak low. So this is the scanning of the Staphylococcus aureus. You can see that the oral mucosa is being spared. So this is the epitic whitlow, just have, infection of the nail bed, the nail, or the surrounding finger. So that's whitlow. It's very, very painful. Can be caused by fungus. It can be also caused by bacteria. It can be caused by what's it called? The virus too. The epitic whitlow. And so many things that can be caused by herpes that we have not mentioned yet. It can cause gingival stomatitis. It can cause encephalitis. It can cause, particularly temporal lobe encephalitis. We are going to enjoy this by the time we, come for the microbiology section. So I don't want to bombard us with a lot of information right now. So let's just move according to what we have. And the next is molluscum contagiosum. Molluscum contagiosum is also caused by a virus, the molluscum contagiosum virus, which is a pox virus. That is the largest DNA virus that we have. And what is classic, to the molluscum contagiosum is just appearance of the lesion. They are going to have this papules with central umbiligation. So central umbiligation meaning you are going to be seeing indentation. So it's very common in children, and most of the time it resolves on its own, right? But in adults, most of the time it's sexually transmitted, in adults. So if you are seeing an adult with molluscum contagiosum, most of the time you will not see it on the face. You will see it in the genital. But in a child, they can have it on their face because they can transmit it from sharing fomites, all those things. So, but for adults, it's usually sexually transmitted and you have to treat it. But for children, you don't necessarily treat it. It's going to resolve on its own. Varicella zoster, that's the human herpes virus type 3, that can cause varicella, which is a chicken pox. And I mentioned it that chicken pox usually they have vesicles. And what you are going to see in the question stem that usually gives out varicella quickly, which is chicken pox, is that they will tell you that the individual is having this, puritic vesicles, maybe that started as papules, changed to vesicle. Now they are changing to, sometimes maybe bullous lesion, and from there they are crusting, and they are healing. So they will tell you that there's like an evolution of the progression of the lesions, like from papules to pustules to vesicle. No, from papules to vesicles to pustules to bullous lesion, and the crust, and that's it. So once you are seeing like that multiple crops of lesion at different stage, you know that this is likely to be varicella. So some of them will be like at the purple stage, some of them will be at vesicle, some of them will be like pustule. This is classic for varicella. And when it resolves, they stay latent. This varicella can stay latent in the ganglion of the nerves. And by the time it's coming back, maybe due to immunosuppression, the person develops HIV, the person is on steroids, the person just, have anything that is causing immunosuppression, stress, malnutrition, and you have reactivation of that virus, is going to come as zoster. And this time around is going to form a dermatoma, configuration. So it can be affecting the side of the chest, like the thorax, the eyes. Let me show us, I know we know that, but just to see what we are talking about, the zoster infection, we just see the vesicles, which is usually painful. Yeah, so affecting the particular dermatome. You can see this is like affecting the thoracic dermatome. You can see the vesicles, numerous vesicles, and like one bully here. You can see this is the epizoster of Tamicus, right? This guy will need a cyclovir IV ASAP unless the person wants to lose the high. So this is the one affecting like the cervical distribution and the like. So that's the way the zoster comes. So it's more like the reactivated form of the varicella infection. And one thing to also take note of for the zoster is that once you are seeing zoster infection that is crossing the midline, so that means you're having a bilateral dermatomal involvement. It is a very severe type. That's like disseminated form. You want to rule out HIV in that person. Very, very important. Very, very important. So the next is the hairy leukoplakia. So leukoplakia, by the time, I'm sure we have done the GIT, right? Have we done GIT?
Yes, we've done it.
So we've done GIT.
Yes.
Dr. Festus will have talked to us about, okay, no, that is step 2. I'm so so sorry about that. This step 2. So, but we will know about leukoplakia. I'm not sure we'll talk about leukoplakia in step 1 GIT. Did we talk about leukoplakia in step 1 GIT? Leukoplakia?
I think,
I don't
I
think
don't
so.
think so, right?
No.
No,
yeah,
okay.
Mm-mm.
yeah, that's where you made
No.
difference with those scrapings. Mm.
Yeah, I doubt it. But it's in step 2. Step 2 stuff. So,
But I know. I think we need to know it for step 1 as well under dermatology.
yes. So, we have, leukoplakia, we have hairy leukoplakia, and of course the thrush. So leukoplakia most of the time can be caused by HPV, can be caused by people that smoke, can be caused by people that takes a lot of alcohol. So they have this whitish, discoloration of their mouth, but it does not have a feathery appearance. You don't see any hair-like patterning to the whitish distribution. No, you don't see anything like that. So that is the leukoplakia, you know. And you now have hairy leukoplakia. Now, the leukoplakia is precancerous. It can lead to squamous cell carcinoma of whatever part, maybe of the mouth, right? The hairy leukoplakia is caused by HBV, not leukoplakia caused by HPV. Leukoplakia without feather, without hair, that one is caused by HPV, smoking, tobacco. The hairy leukoplakia, when you look at the whitish stuff, it's going to have a feathery pattern, like as if there's small hair there. That's your hairy leukoplakia. That one is caused by EBV, by Epstein-Barr virus. Hairy leukoplakia. It has no malignant potential. They put it in the question stem that what's going to be the complication of this. Pick nothing. Do not pick cancer. Don't fall for the trap. It has no malignant, it has no cancerous potential. It doesn't cause cancer. But the leukoplakia can cause cancer. Then the last one is the oral thrush. So that's the one from Candida. I want to leave it with you that Candida is not, oral thrush from Candida is not an health-defining illness. Meaning, if you see an individual with oral thrush, do not assume that that person is having AIDS. It is not an AIDS-defining illness. So the person might be taking steroid for asthma or something, can lead to thrush. So it is not. But if somebody is not having, thrush extending to the esophagus, okay, we cannot say that this guy is having HIV. That's AIDS-defining. So don't fall for it. So the oral thrush from Candida can be caused by so many things. AIDS is one of them. Steroid use is another one. And you can scrape off the lesion. Although the lesion might bleed, but it's scrapable, right? But for leukoplakia or hairy leukoplakia, you cannot scrape it. It's unscrapable. So don't forget. Don't forget. So you can have the hairy leukoplakia too in people that have HIV, organ transplants, because they have a high risk of acquiring this Epstein-Barr infection and developing the lesion. So don't forget about that. Don't forget about that. Moving on to the cutaneous mycosis. Cutaneous
I
mycosis.
have a question.
Okay, I'm with you.
Okay, because I have a question. Yeah, just it is still under the distinguishing between the leukoplakia and hairy leukoplakia.
Mhm.
I just want to clarify. Did you say both of them can be are unscrapable?
Yes.
For both the
Hairy,
leukoplakia and hairy leukoplakia?
yes. Leukoplakia and hairy leukoplakia, you cannot scrape both of them. Do you
Okay,
understand? The only one you can
okay,
scrape is thrush.
okay.
That's it.
And,
So
and in terms of the malignant potential, it's only the leukoplakia that is precancerous that can convert to squamous cell. The
fantastic.
hairy leukoplakia is not pre-malignant. Am I
Fantastic.
correct?
That's very
Okay,
correct.
thank you.
So, cutaneous mycosis. So we are talking about the tinea infection. That's dermatophytes. That is fungal infection that cause skin problems. So we have to be familiar with the three organisms. Very important: microsporum, trichophyton, and epidermophyton. So I put you on that time. Trichophyton, microsporum, and epidermophyton. One thing you want to hold for this guy is that whenever you see puritic infection in the body, aside our atopic dermatitis and the likes, you also want to consider tinea infection. But the way they would describe it, you know that this is tinea and this is not atopic dermatitis. They are puritic. If that's the only thing you know about, in fact, if somebody tells you, tell me about tinea infection, I start with most of it. They are caused by time, your trichophyton, your microsporum, and epidermophyton, and their purity, they will tell you to stop that. Okay, this one has an understanding of what they are talking about. Because there's no way you miss diagnosis once you are able to identify that they are very puritic. If you do the staining of the tinea infection on your blue fungal stain, you are going to see the septate hyphae that is branching. Very, 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 very important stuff. See, image A, there's going to be branches of the hyphae. It's going to be septated. Septated means you are going to be seeing some crossing, then it will be branching, branching. By the time we come to microbiology, we start talking about the branching, aspergillus branching at 45, so many of those guys branching at different things. So you have to hold on to the fact that the tinea dermatophytes, they branch, and they have a septated hyphae. So it helps you in making the diagnosis because the question will talk about it, and they are puritic and they are caused by time. So the commonest of this time is actually trichophyton, but trust me, they were not going to ask you the epidemiology stuff. But just know that most of the time it's trichophyton that is involved. So what are the types of tinea infection? So number one is tinea capitis. And tinea capitis is just the tinea infection of the head. And what are you going to see? Alopecia, areas of scarring, with scaly, what's it called? Lesion. So the tinea infection are very scaly. They cause scaly problems. So you are going to be seeing scaly lesions with area of patches. Once you are seeing this, you know that this is tinea capitis. Step two, they like asking that question like mad. What do you want to do for this patient? So if you go and pick topical antifungal, that is zero. So it is a express statement. Step two, treatment anywhere. I don't know if you can come out in step one, but I'm going to mention it because it's high yield. Anybody with tinea capitis or tinea infection of the nails, you have to give them oral medication. You have to give them oral medication. What I've said, we need to be telling it to people so that you don't forget. High yield stuff. Tinea capitis infection, tinea infection of the nails, you need something that can penetrate those hair, those appendages. Give it orally. Don't apply topically. It will not work. Tinea capitis. The next is tinea corporis. Tinea corporis is not the one affecting the head now, but the one affecting the body. Area where you have glabrous skin, hairless skin, right? And what are you going to see? You are going to be seeing still the scaly lesion, erythematous, with central clearing. So look at this, erythematous lesion, with central clearing. That is your, what's it called? Your tinea corporis, right? It can be gotten from contact with farm animals, with pets, all those things. So that is tinea corporis, very puritic. Then the next is the tinea cruzi, or the cruris rather, not cruzi now. Cruises and that in entirely. So the cruris, so the one that we call the joker hitch, so in between the groin. So the difference between this and corporis is that this one doesn't have any central clearing. You just have erythematous lesion widespread, and it is very puritic. They'll be scratching this thing like mad. Very puritic stuff. So that's it. They will just be telling you this person just scratching. You know that this is likely to be tinea cruris, very important. Then the tinea pedis, that's the one that affects the toes, right? You have three distribution. You can have an interdigital, very puritic interdigital, scratching the. You see, that's why step 2 they will tell you. So, what do you want to do next? Once you see somebody having this constant scratching, and the next thing you want to do is to search for another focus of infection, because most of the time it is due to auto-inoculation. There's somewhere else that the lesion is that is transferring to another place. For example, it could be that this person is having the lesion in the groin. Now, because it's already scratching that groin and touching the head or touching the leg, that is how the person is able to spread it to the head or to the leg. So after you have identified that one, the next thing is to look for other potential focus. That is not you jumping to medication straight. Because if you give medication, you might not clear for example, if you are giving medication for, what's it called, for tinea cruris, and you're applying topical stuff, it's not going to cure the one on the head, right? Because that one will require oral, and you have done nothing. So search for other stuff, because the cause of the tinea stuff is usually auto-inoculation from other stuff, from other areas. So, and maybe they have been in contact with farm animals, with pets like cats, dogs, and the likes. So, the tinea pedis, like I'm saying, three forms, just like we have here. The interdigital, which is the commonest. It's also known as the Hartley foot. We have the moccasin distribution and the vesicular type. So, what they are just trying to tell us here is that we can have these scaly erythematous erosions, in the space in between the digits. That's the interdigital one. You can have it, along the sole of the foot. That is a moccasin distribution. Then the vesicular one is that you can have like vesicles within the medial aspect of the leg. That's just it. Everything is still affecting leg, and they are scratching it. So forget about the type. Tinea pedis is tinea pedis. The last is the tinea unguum. So this is the one that is affecting the nails. So you have what we call onychomycosis. So sometimes you have the nails deformed. You see some people, you look at their nails, you see it deformed. It's not due to shoe, it is due to fungal infection. So onychomycosis. So destroy the nail bed. It looks very bad. Something like this, and they break, snap. So this guy now, you have to place on what type of medication? Anybody? What type of medication are we going to
Or
give this?
oral antifungal.
Oral medication. Oral medication.
We are going to give that person oral medication. Very important. So we're already getting prepared for step 2. So that's tinea unguum. Then moving on to tinea or pityriasis versicolor. Now, do not mistake tinea or pityriasis versicolor for a dermatophyte. It is not a tinea infection. It's just a misnomer. It is caused by malassezia. So what other skin lesion is caused by malassezia species? Anybody remembers?
Seborrheic dermatitis.
Seborrheic dermatitis. Fantastic. So tinea or pityriasis versicolor is also caused by malassezia, just like seborrheic dermatitis. That's how you palm all these things together. You link your stuff so you don't forget. So it is a yeast-like fungus, not a dermatophyte. Don't make that mistake. They can put it in the option. They will paint scenario of somebody with pityriasis versicolor. They even name it tinea or something, and you just remember, oh, this is tinea versicolor now, and the next thing you are picking in the option, a dermatophyte. So you'll be wrong. It is not a dermatophyte, even though it bears tinea. So it is caused by malassezia. And this malassezia guy, just like we know from seborrheic knowledge, he likes, feeding on lipids, sebum, and the like. So it metabolizes this lipids and produces some acid, like azelaic acid. And these acids inhibit the activity of your thyroxinase enzyme. So, which is an enzyme that is absent in people with albinism. And when that happens, they cannot produce melanin anymore. and there's going to be hypopigmentation. So that is why people with tinea versicolor, they have problem with the skin color. Tinea versicolor. You'll be seeing areas of hypopigmentation alternating with areas of hyperpigmentation, just like image G. For some of us that are Yoruba here, that is what we call, anybody knows what we call this in Yoruba? Anybody knows? Anybody knows?
Ifo.
Ifo, yes. So that is what we call Ifo. So areas of hypopigmentation alternating with hyperpigmentation. But the most conspicuous is the hypopigmentation. And don't be surprised if that is the only stuff that is mentioned in the question. So I'm not saying that we should not be looking for, okay, alternating. Sometimes they can just say hypopigmentation, because that's the major stuff. Inhibit, they metabolize the lipid, the product inhibit thyroxinase, they cannot form melanin, there's hypopigmentation. Now, they can have hyperpigmentation because of inflammatory response to the infection. So because of the inflammation, it can cause hyperpigmentation. And you can see there's a clause here, it is less pyretic as compared to your dermatophyte. So that is very significant. And most of the time it occurs during some particular period, like hot period, like summer, hot, humid weather where everybody is sweaty. So you can easily have that malassezia guy transforming into a pathogenic strain and, causing problems with the skin. So probably people that don't take their bath, they shower regularly and they are just sweating, they are wearing the same clothes every time. So they can have this infection. Now, this is not the infection that when you do your KOH mounting or you do your fungal blue stain that you are going to be seeing septated branching hyphae. No, that is what you see for tinea. Here, you are going to be seeing the spaghetti and the meatball appearance. So this just means that you are seeing your hyphae with the spores on it. So these are the spores. So the spores are the meatball, while the spaghetti is the hyphae. That's the stick holding the meatball. So once you are seeing clusters of spores with the hyphae, that's the spaghetti meatball appearance. For what? For tinea or pityriasis versicolor. Very important stuff. Very, very important stuff. So we can see that this one is not spaghetti meatball. This is a spaghetti meatball. What do? We know that the implicating organism is malassezia. Just like what we do for people with seborrheic dermatitis. We give them what? Topical agents like selenium sulfide, like the zinc parathion. And in extreme cases, you might give them oral antifungal like maybe ketoconazole. They are going to be fine. So don't forget it's caused by malassezia. Very important stuff. I think I have some questions here. Let me see. A 17-year-old boy comes to the physician because of a non-pyretic rash on his chest for 1 week. He returned from a trip to Puerto Rico 10 days ago. He started using a new laundry detergent after returning. He has type 1 DM, controlled with insulin. His mother has Hashimoto. The sister has severe facial acne. Examination of the skin shows multiple non-tender round hypopigmented markers on the chest and trunk. There's a fine scaling when the lesions are scraped with a spatula. Which of the following is the most likely mechanism of the patient's symptoms? What do we think? Anybody?
Is it infection with Trichophyton rubrum?
So, okay, please,
It's
infection.
with
Let's see of
wait. So,
names.
sorry, class. I just want to ask a question. So, somebody said infection with Trichophyton rubrum. Okay, so the person is thinking of dermatophyte, right? Doc.
Yeah, right.
Yeah. So, what is the first thing you have to consider if you are thinking of dermatophyte? What do you check for? What particular symptom do you expect?
Itchiness.
itching, right? Pruritus, right?
Yes.
So, but if we go back to this question, do we have anything in keeping with pruritus? They told us that the lesion is non-puritic.
Hmm.
So
Yeah.
we take that out totally.
Increased growth of malassezia.
Yeah.
Oh yeah,
So
malassezia.
so this is pityriasis versicolor. I forgot to mention that they can be scaly. I forgot to mention that. So if you peel it, sometimes you see that they are, scaly. And also, it's also important to emphasize the distribution. It's very common in areas that are like the upper part of the body. It's not exposed, like the chest, the trunk. That's where they have the lesion. And sometimes when you scale it off, you can see the scales. You rub it, you can see the scales coming out. So of course it can be A. This is not vitiligo. So because vitiligo will not have scaling, you know, and what else again? It's not albinism, you know.
What about C?
Yeah, so that's why I said it's not albinism. C is albinism, right?
Yeah.
Deficiency of, so
Mm.
it's not albinism. And
Please, globosa and furfura the same thing?
yeah, so that's why I said Malassezia species. So it can be globosa, it
Okay.
can be furfur, any one of them.
Doctor, Babon.
Yes.
But the degradation, the malassezia degrades the lipids and then it inhibits the thyrosinase, right?
Mm-hmm.
Yeah.
Yeah. Okay, so let's
So
go back to the question.
the
Yeah.
C that said the
Mm-hmm.
other one is completely like deficiency, so it's like
So
completely
exactly deficiency.
okay.
So that means
Okay.
they're thinking it along albinism. Okay. So um moving on to the autoimmune blistering skin disorder. So these ones are a little bit more interesting. And we have two of them majorly. The pemphigus vulgaris and the bullous pemphigoid. The pemphigus vulgaris and the bullous pemphigoid. One thing that we have to have at the back of our mind before we make diagnosis of any one of these, if we are with a group of people and we are solving questions, or we are solving questions ourselves, either maybe during our own personal study or in the exam, before you make diagnosis of pemphigoid vulgaris or bullous pemphigoid, look at the age. This information I'm giving you is going to help you anytime you find yourself in a dilemma. Just look at the age. Once a person is less than 40, please don't even think about pemphigoid anything. It's not going to be the answer. Pemphigoid vulgaris, the age is usually between 40 to 60 years. The bullous pemphigoid is usually more than 6 years. So this problem is a problem of old people, not young people. That's number one stuff. The number two stuff is that both of them are type 2 hypersensitivity reactions. Because we have not done immunology, it just means that the hypersensitivity is mediated by antibody factor only. It is only the antibody that is at work, not the antibody antigen complex. It is only an antibody that is destroying something. Now, each of them have different antibody attacking something. They are all autoimmune disease, don't forget. That means you have antibody attacking something. For pemphigoid vulgaris, I think I will finish with pemphigoid vulgaris, then I will go to bullous pemphigoid. Pemphigoid vulgaris is more severe compared to bullous pemphigoid. Number one, pemphigoid vulgaris starts from the mouth. It affects the oral mucosa. And from there, it progresses to affect the body. And the problem in pemphigoid vulgaris is that there is IgG antibodies directed towards the desmoglein 3 and the 1, which separate the keratinocytes in the stratum, that of the stratum granulosum from the stratum spinosum. Unlike that of SSS that majorly affect the stratum granulosum. So separate them and you have, you can easily separate, those epithelial cells and they can easily rupture as well. If they form bullous lesion, they can easily rupture because there's no tight connection in between them. So That's basically what you have in pemphigoid vulgaris. IgG against desmoglein 3 and 1. Now, what are the characteristic lesions that you are going to see? So you are going to be seeing flaccid intraepidermal bullae. The reason is that just imagine that you have epithelial cells being separated. Once there's separation, it means you have space for fluid to be accumulating. So fluid is going to accumulate and they are going to be transformed into bullous lesion. But because of the fact that there is no tight connection in between them, those bullous lesions can easily rupture. So that's why they are flaccid. That is a key point you are looking for in the history or in the image. Once you are seeing that there is rupture, you know that this is flaccid bullae and it is not tense. And that is in keeping with pemphigoid vulgaris. Don't forget the oral mucosa is involved. So the mouth is involved, they cannot even eat. The bullae are flaccid, they are rupturing easily, they are going to be prone to dehydration. Infection can enter. That's why we consider it as being potentially fatal compared to the bullous type. You can also elicit the Nikolsky sign. Of course, something that is flaccid. That means that if you just put your hand on it, it don't burst. Nikolsky sign is going to be positive in the pemphigoid vulgaris. Then, if you do your immunofluorescence, you are going to be seeing reticular pattern around the epidermal cell. Now, let me explain what they are talking about here. Immunofluorescence is just more like a form of microscopy in a way that allows you to see the pattern of antibody deposition. Now, let us look at the image that is beneath. This is a normal skin. This is your epidermis. This is your epithelium. This is the epidermis. This is the dermis. This is the basement membrane, right? Now, this is the skin of somebody with pemphigoid vulgaris. We can see that we have intraepidermal separation. People, can we see this? Can we appreciate this?
Yes.
And we can see this white stuff that's talking about the antibodies, depositing in those areas, destroying the desmoglein. So this is where the antibodies are going to be depositing. That is a pattern of the antibody deposition. Now, that is what we want to see with our immunofluorescence. Immunofluorescence is going to be showing us the way the antibodies are patterned. So it is going to appear like this. We are going to be seeing this space, 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 space. So this is what we are going to be seeing, right? And this looks like a reticulated network, like fishnet appearance, reticular pattern, because what you are having is separation within the epidermis. So that is classic for pemphigoid vulgaris, a reticular pattern on immunofluorescence. You know that what they are talking about is what? Pemphigoid vulgaris. Now let us go back to the other guy. Now, bullous pemphigoid occurs in people that are more than 60 years. It is also a type 2 hypersensitivity reaction. As compared to pemphigoid vulgaris, it is pyretic. Pemphigoid vulgaris is not pyretic, it is painful. But people with bullous pemphigoid, they find their whole pyretic, they are scratching it. It doesn't pain them, but they are just itchy, right? And it is due to IgG deposited against hemidesmosome. Now, where do we have hemidesmosomes? They connect the basement, the basal layer of the epidermis to what? The basement membrane. Don't forget, I said this, right? Now, it means that the separation is going to be distal at this portion. Do we think this is going to give us a reticulated appearance? No.
No.
It is not going to give us a reticulated appearance because the problem is down here between the basement membrane and the distal or the stratum basale of the epidermis. Now, the configuration we are going to be seeing here is linear. We are just going to be seeing like something like this, linear configuration. Once you are saying linear antibody deposition configuration on your, what's it called? That is your bullous pemphigoid. Now, we don't need to cram this thing. If you are confused in the exam hall, you just need to take your time to process and look at the level where the lesion is happening. You will definitely figure it out. If it's within the epidermal cells, it's going to be reticulated. If it's distal between the basement membrane and the stratum basale, it's just going to lift off the stratum basale and there's going to be a linear deposit of the antibody, and you are going to see a linear pattern. So a linear pattern at the epidermal dermal junction. It is as simple as that. Now, why is this lesion tense and not flaccid? This is where the spaces are formed. This is where water is going to be accumulating. Now, this basement membrane is very strong. It can cushion compression and they will not rupture. But if the water is accumulating here, all these ones can easily shift and they will rupture. But the basement membrane is intact. So it exerts a cushioning effect and the bullae or the blisters will never rupture. Do we understand that? So it's going to be forming a tense bullae, a tense blister instead of a flaccid blister like in pemphigoid. And the Nikolsky sign is going to be negative. So can we tell the difference now between pemphigoid vulgaris and bullous pemphigoid?
Yes.
Yes.
Now,
Yes.
there's a
Yes.
last information I want to leave us with, and that is what we call role of thumb appearance on electron microscopy. You see that in people with pemphigoid vulgaris and what they are just talking about. If we look at this image, the one that looks like roll of thumb, like all these white people, the way they bury their, they are dead, they put all these things at the grave. You can see that the stratum basale is the one that looks like a roll of thumb, right? So anyone that does not disrupt the stratum basale, you are going to see the roll of thumb. So in pemphigoid vulgaris, everywhere above is scattered, but your stratum basale is what is intact. So this is the only normal thing you are going to be seeing on electron microscopy, and that is what we call the roll of thumb appearance. But here we have lifted off the stratum basale, so it's kind of distorted. So that roll of thumb configuration is lost. So if you are seeing on H and E stain, roll of thumb, you know that is pemphigoid vulgaris. The bullae is going to be flaccid, unlike this that is going to be tense. No roll of thumb. Your ram mucosa is spared. Nikolsky sign is negative. It's very easy. There's no catch. Just look at the bullae. We can see that this one is tense, so we can see this is bullous. This one is flaccid. This one is what? Pemphigoid vulgaris. We can see the reticulated distribution here. Pemphigoid vulgaris. We can see the linear, split. We can see the splitting somewhere here. So this is a linear, pattern of what's it called? Of bullous pemphigoid at the epidermal dermal junction. So high dose steroid is the mainstay of treatment. Moving on to the other blistering disorders, the next is dermatitis epiphthiformis. We don't need too much information.
Doc, what did you say is the treatment? I couldn't hear you properly.
High dose
You said
steroid. High dose steroid.
high dose treatment, a steroid. Okay, thank you.
So dermatitis epiphthiformis, what these individuals will be having is just bilaterally symmetrical. Bilaterally symmetrical. As you can see, I added it. Bilaterally symmetrical, puritic papules, vesicles, so they can form papules, they can form vesicles, they can form bullous lesion. So that's why it's classified under blistering skin conditions. But where are we going to be seeing these puritic papules, vesicles, or bullae that will raise our suspicion for dermatitis epiphthiformis? Dermatitis epiphthiformis. You are going to see them at the extensor surface, the buttocks, the elbows, the knee. So this is not psoriasis, because in psoriasis it's going to be what? Papules and what? Plaques with silvery white scales, right? But here we are just having puritic papules, vesicles, or bullae at the elbow, the knees, the buttocks. That is bilaterally symmetrical. They are not going to stop there. They are going to tell you another thing. They can link it to celiac disease. They can tell you that the person is having malabsorption issue. Maybe the person is having diarrhea, the person is having malnutrition, whatever, steatorrhea or something. And they can even tell us that features of celiac. Anybody wants to tell us the histological features of celiac disease? Anybody?
Yeah, they have atrophy, villous atrophy. They
Velocitrophy.
have intra
Lymphoplasma.
Intraepithelial.
intraepithelial lymphocytosis
Okay.
and crypt hyperplasia.
Crypt. Yes.
Yes. So they are going to mention that. They can mention those DRQ, 2, whatever. They can put all those things, the HLA, and maybe they might, but that would be too generous, telling us that the person is sensitive to gluten or something. They might not put that. So, but they will link it to celiac disease, and just to, make you aware that, okay, this is a skin disease that is linked to celiac disease, and that's dermatitis epiphthiformis. I don't want to go into the details of how everything happens, but just know that sorry, excuse me, we are going to see deposit of IgA at the tips of the dermal papillae of the skin. So that's part of what we are going to find. When we do the biopsy, we can see IgA deposit as well as neutrophilic deposit. So neutrophilic deposit, IgA deposit. Remember, IgA plays a very serious role in celiac disease because IgA is antibody of the mucosa, right? The GI mucosa. So IgA deposit in the dermal papillae of the skin. Your neutrophils also deposit there, and that forms the neutrophilic dermal papillary microabscess. Where do we have the Muro microabscess?
Psoriasis.
In psoriasis. So very important stuff. So what do? You just give them Dapsone, and if they are taking gluten, you discontinue the gluten because the gluten can trigger the inflammatory stuff. So very important. Then moving on. So this is an example of the dermatitis epiphthiformis. You can see the papules, the vesicles that have ruptured, at the elbow. So erythema multiforme is commonly tested, right? And it's very common in people with some
Doctor,
certain.
I think we left something out.
What is that?
After the autoimmune, we left the epidermolysis bullosa simplex. All that is not fine.
No, it's not there.
Okay.
I think it's been removed here.
Okay.
Yeah, they removed
All
it.
right.
They removed it.
Okay. All right.
So
All right. Thank you.
we can just read that. We can just read that for just for our knowledge. The
Okay.
very common in childhood. They have their skin rupturing, all those things. So
Okay.
so erythema multiforme, it's very associated with some infections like mycoplasma pneumoniae and HSV. The commonest cause of erythema multiforme is actually HSV. Very important stuff. HSV is the most important cause of erythema multiforme. Mycoplasma pneumoniae too can cause it, right? And it can also come from other drugs like sulfa drugs, people that use beta-lactam, allopurinol, phenytoin. They can also have this erythema multiforme. And it can present so many ways. You can have macule, papule, vesicles, target lesions, but the first thing is to be able to identify what erythema multiforme looks like. And they have this targetoid appearance. So you are going to see, is a alternus erythematosus area with a central, dusky, dark lesion, like a target point. So once you are seeing something like this, like all these people that play that board, that configuration, erythematosus, clear zone, and the central dusky erythema multiforme. You want to ask yourself, anything suggestive of HSV? Nothing. Okay. Mycoplasma pneumoniae? Oh, yes. How would they put it? They can tell you that the person is like a 10-year-old boy. Anybody that is going to be having mycoplasma pneumonia is going to be young, number 1 point. We are going to talk about that in microbiology. They're usually young. And because there is an atypical cause of pneumonia, they don't have cough. They don't have productive cough, rather. They have cough, but it is non-productive. So those are the things you are looking out for in your exam. Somebody is coughing. Another person will just be glossing over the pattern of the cough. They don't know what they are looking for. The fact that cough is productive is telling you something. If it's productive, you are looking at strep pneumo, cleb, all those typical causes of pneumonia. But if it's non-productive, okay, this could be from atypical cause, like maybe mycoplasma, legionella, pneumocystic, all those things. So, so they will tell you that the young fella, having cough that is non-productive, the person having rash, it's like they have spoon-fed us totally. That is mycoplasma pneumonia until otherwise proven. So it can also come from drugs. So the person used some medications and subsequently after some few days or weeks start developing the targeted lesions. Sulfur drugs, beta-lactam, phenytoin. In fact, this guy, they go hand in hand in causing so many problems like this. Sulfur drugs, beta-lactam, phenytoin. They can cause Steven Johnson, they can cause toxic epidermal necrolysis, they can cause DRESS syndrome. So, which I think we talk about the DRESS in step 2. Drug reaction with eosinophilia and systemic symptoms. I think that's in step 2. I'm not sure it's here. So, but these guys are very notorious for causing widespread problems. Don't forget the pattern of the rash, the erythema, and the central dusky necrotic area. So that is erythema multiforme. HSV, mycoplasma pneumoniae, and infection. And what? Drugs. Moving on to Steven Johnson syndrome. Steven Johnson syndrome. Now, Steven Johnson syndrome and toxic epidermal necrolysis, they are like a spectrum. And what is peculiar to these guys? Most of the time, they are provoked by medication use and less commonly by infection. 90% of the cases, it is drug. It is drug. They will tell you this person don't use drug. That is why the person is having the rash. How is it going to start? They start with having fever. After the fever, they start having squamous, like desquamation of the skin. The skin will start sloughing off. They can start with macules, papules, purpuric lesion. Then later, they start having sloughing of necrosis of the skin. Start sloughing off, like that. And you quickly go and look at the mucosa. Is the mucosa affected? Yes. This is likely to be SGS or TN. Is the mucosa not affected? Okay. It could be staphylococcal scarlet skin syndrome. So, fever, desquamation, mucosal involvement, Steven Johnson, Steven Johnson, Steven Johnson. You can also see the targeted lesion of erythema multiforme. It can be there, and it usually comes from adverse drug reaction. They must have used some particular drugs. Now, what are these drugs? Same as what we have here, the sulfur drugs, the beta-lactams, cephalosporin, penicillin, the anti-epileptics, particularly carbamazepine, phenytoin, and lamotrigine. There's no way you can forget what I'm saying. Phenytoin, lamotrigine, and what? And carbamazepine. They are notorious. Allopurinol is another drug, that can cause what's it called? That can cause Steven Johnson syndrome. Now, to now know if what we are dealing with is Steven Johnson syndrome or toxic epidermal necrolysis, you have to look at the surface area. I'm going to show us how we calculate surface area when we get to burns. It's very simple. So if 10% of the skin is involved, you pick SGS. If 30% and more of the skin is involved, you pick TN. If it's in between, you are going to pick both of them. So that's the way it is. So they test this concept a lot. Don't forget, the Steven Johnson syndrome and the toxic epidermal necrolysis, I have to mention it, that it is a form of type 4 hypersensitivity response. You have your T cells at work, and they are the ones destroying, sloughing off the skin, particularly at the dermal epidermal junction. So that's where they are, destroying the connections. And they also elicit a positive Nikolsky sign, right? The mortality is very high. So you need to be aggressive with your treatment, your fluid resuscitation, antibiotic cover, pain relief, stopping the medication, everything like that. So Don't forget type 4 hypersensitivity as compared to staphylococcal scarred skin, that is what due to Staphylococcus aureus infection. Staph aureus, the separation is at the stratum granulosum from desmoglein, whatever. But in TN, SGS, type 4 hypersensitivity, your T cells are the one destroying the dermal epidermal junction, causing the sloughing off of the skin. Nicosis sign is possible in both, but there's mucosal involvement in SGS. There is no mucosal involvement in staphylococcal scarred skin, only perioral crusting. Don't forget. Okay, so this is a patient now. Image D is showing the skin, desquamation, kind of. You can see the blisters already forming here. Skin has already shed, so, affect the mouth everywhere. Just like this guy, the mouth is already affected. So you think of Steven Johnson. So it's not only the mouth, because we have said mucosa, it could affect the eyes. They could be having conjunctivitis, it could affect the genitals. So all those areas are mucosa, not only the mouth. So let me see. I think we have some questions here.
Doc, can you elaborate on those percentages again? The 30%, that, and the in between, and all that.
So for now, I don't want you to worry about calculating the percentage. I'm going to show us how to calculate it. For now,
Okay.
I just want us to know the values. For we to say that it is SGS, it has to affect 10% and less of the skin.
Okay.
For we to call it TN, it has to affect 30% and more of the skin. So for we to call it SGS TN, both of them together, it has to be between 10 to 30.
Okay.
Do we understand that?
Yeah.
Okay.
Thank you.
You're welcome. So this is the what? This is a question. A 66-year-old man comes to the physician because of 1 week history of pruritic blister formation. Physical examination shows 1 to 3 bullae on the palm, the sole, the legs, inguinal foot. Gentle rubbing of the skin do not result in sloughing of the epidermis. What sign is that?
Nikolsky sign.
Which is it negative or positive?
Negative.
Negative.
So immunofluorescence study of the perilesional skin biopsy specimen are most likely to show deposition of antibodies in which of following area. This is spot diagnosis. So which area?
Bullous pemphigus.
And the
Yes,
Epidermal junction.
stratum basalis. Yeah.
exactly. So the dermal junction, option A.
Junction. Yeah.
A 52-year-old woman with, let's look at the age, 66. You can see that the age is more than 60. A 52-year-old woman with type 2 DM comes to the physician because of 2-day history of blisters on her arms and pain during sexual intercourse. Her only medication are metformin and glyburide. Examination shows multiple flaccid blisters on the volar surface of the forearms and ulcers on the buccal, gingival, and vulvar mucosa. The epidermis on the forearm separates when the skin is slightly stroked. Which of following is the most likely diagnosis?
Pemphigus vulgaris.
Very simple, very simple.
Yeah.
A 54-year-old woman comes to the physician because of painful blisters under the arms that appeared 3 days ago. She also has had a 2-month history of intermittent painful lesions in the mouth. Examination of the mouth shows several erosions on the buccal mucosa and lips. Examination of the trunk shows multiple flaccid blisters with diameter of about 2, blah, blah. Skin biopsy obtained from the area around the lesion shows detachment of keratinocyte within the strand of which so where is the antibodies directed to?
Desmosomes.
Pemphigus vulgaris.
Pemphigus vulgaris. I thought I have one more question on the particular stuff. It did not say. Maybe I'll see it somewhere else. Okay, let's just continue. Let's check this. A 24-year-old man. Okay, this is a question. A 24-year-old man comes to the physician for evaluation of a severely pruritic skin rash. Physical examination shows a symmetrical rash over the knees and elbows with tense group vesicles and several escoriation marks. Microabscess in the papillary dermis are seen on light microscopy. Immunofluorescence shows deposit of immunoglobulin A at the tips of the dermal papillae. The patient's skin findings are most likely associated with each of the following. What's our diagnosis first?
I think it's celiac disease. I think it's
Diabetes herpetiformis.
Dermatitis.
So
Dermatitis.
gliadin dependent hypersensitivity.
Okay. Good job. So the nail pitting, which one is that?
Psoriasis.
Psoriasis. Okay. A 50-year-old woman comes to the emergency department because of 3-day history of malaise, dysuria, blood vision, and painful itchy rash. Malaise, dysuria, blood vision, and painful itchy rash. The rash began on her chest and face and spread to her limbs, palms, and sole. 1 week ago, she was diagnosed with trigeminal neuralgia and she was started on a new medicine. She appears ill. Temperature is 38. Pulse is 110. Physical examination shows conjunctival injection and ulceration of the tongue and the palate. There is no lymphadenopathy. Examination of the skin shows confluent annular erythematous macule, bulle, disquamation of the palm and the sole. The epidermis separates when the skin is slightly strobed. Which of the following is the most likely diagnosis? Anybody?
Steven Johnson.
Steven Johnson's. Everything is just very straightforward. We have all the clinchers like right there. What drug do we think is provoking
So, but
this?
what's the difference
Carbamazepine.
between
Carbamazepine.
Yeah.
Somebody was asking.
Sorry, please. I said, what's the difference between Stevie Johnson and Dread syndrome? Because I know these anticonvulsants also have side effects of Dread syndrome. So I don't know the skin manifestation.
So most of the time, your dress syndrome will not have Nikolsky sign being positive. That's number one stuff, right? And most of the time for dress syndrome, they will put a lot of systemic manifestation. Right here now, we don't have any, we don't have any liver issue, we don't have any kidney. So they will put, some liver stuff there, just to show you that okay, there's some systemic manifestation. And most of the time, the rash, is like maculopapular, confined to the face and maybe the trunk, and it does not disquamate like like that of what's it called, like SGS.
Stevie Johnson.
Nikolsky sign is not positive in Dress syndrome. Do you understand that again? And here, we don't have any systemic, manifestation. So that's it. So in Dress, you will see the maculopapular rash. You will see systemic, problems, organ involvement, and they also tell you that when they did biopsy, they are seeing eosinophilic infiltrate everywhere. So you know that this is stress. Do you understand? And your Nikolsky sign will not be positive. Do you understand, Doc?
All right. Yes, please. Thank you so much.
You're welcome. So moving on to the ulcers. Very simple. I'm not going to waste too much time. It's very simple. I might not talk about everything, but trust me, I'm talking about what you need. That's all. The number one is the venous ulcer, right? The cause of venous ulcer is a chronic venous insufficiency. Anything that causes venous stasis in the leg is going to lead to venous ulcer. This person is standing for too long, maybe from pregnancy, that is causing chronic venous insufficiency, or the person is obese, or the person is having like recurrent DVT, or there's a family history, or the person is a smoker. All these things can lead to, what's called CV high, chronic venous insufficiency, prolonged standing, obesity, recurrent DVT, family history, smoker, all those things, chronic venous insufficiency. And what are you going to see that will make you know that, okay, somebody is having chronic venous insufficiency? When you look at the leg, you are going to be seeing telangiectasia. Because when there is chronic venous insufficiency, it means that you're having reflux of blood, venous blood, back into the superficial veins, bypassing the valves. So you are going to be having opening of new of those superficial veins as telangiectasias. You are going to be seeing varicose veins, tortuous dilatation of those veins. There's going to be edema from extravasation of the fluid, stasis dermatitis. So those blood containing hemoglobin deposits, everything is going to macerate that skin and is going to be appearing eczematous, right? I think I have an image, just like what we have here. This is the eczema I'm talking about. So once you are seeing all these things in the leg, you know that this person is actually joking with what? A venous ulcer. Now, where is going to be the area of the ulcer? You have to know that the ulcer for venous problem is going to be located at the gator area. So gator area is just area above the medial malleolus of the skin, of the leg. This is the medial malleolus around here. So that's where you are going to be having that ulcer. And just picture people that wear leg chain, where that leg chain is settling in, that's the gator area. That's where you have venous ulcer. Once you are seeing that, just go and pick venous ulcer and just go and rest. Very simple. The arterial ulcer, you are not going to be seeing telangiectasia, varicose vein, stasis dermatitis. No. What you are going to be seeing is a risk factor for atherosclerotic disease. They can tell you that the person is having MI, having DM, peripheral arterial disease, because there's going to be atherosclerotic occlusion of that vessel. And what you are going to be seeing, the signs, is that by the time you examine, you notice that there's no pulse in the leg. So dorsalis pedis pulse is reduced, posterior tibial artery pulse is reduced. You look at the skin, it's looking cold, and pale because blood is not getting there. They will tell you that the skin is wrinkled, atrophic, hairless. These are classic features of arterial ulcer impending. Now, the pain there is going to be very severe because this individual is going to be having ischemic pain. Ischemia is very painful. Just imagine people with MI, they are screaming of pain, chest pain, yeah. Same thing happens here. It's very, very painful. Ischemia. Now, if you look at the ulcer, it's not going to be seen at the gator area. So most of the time, you can see it beneath the sole here. You can see it in the anterior shin. You can also see it in the distal toes. And they will tell you that the ulcer is punched out, meaning that ulcer, paradoxically, is more elevated by the surrounding tissue. I know that can sound paradoxical, but that is what it actually looks like. It's as if it's raised compared to the surrounding tissue, punched out ulcer. But you don't need to be remembering all this grammar. What you just need to know is that where is this ulcer located at, and what are the other associated, features. Am I having pulse? No. Is it shiny? Yes, because it's airless. Is it cold? Yes. It's pale? Yes. This person is having atherosclerosis, causing peripheral arterial disease. Arterial ulcer, you move. The next is neuropathic ulcer. So most of the time they will have something that is affecting the nerve function, maybe from DM, peripheral neuropathy, right? And you typically see it at pressure points, bony prominences, like commonly the heel and the base of the metatarsals. Don't forget arterial ulcer, you see it here. You can see that the toes, the distal toes or the anterior shin, right? Dorsalis pedis, you know where it is. The toes, the side of the leg, that's where you see arterial. For neuropathic, you see it at the base of the metatarsal, where the pressure is being exerted, and the heel, and there's going to be features of neural compromise, peripheral neuropathy, and all those things. Forget about the description. It's good to know it. You can see about paralytic, but it's not going to really do much. It's not going to be painful because the nerves are gone. So the individual is not going to feel pain, as opposed to arterial and venous that they feel pain. But arterial pain is much more severe, right? So pain is absent in neuropathic. Pain is absent in neuropathic. What are the other associated signs? The pulse might be there, yeah. There might not be any varicose vein, yeah, but you are going to be seeing some joint deformities. So they can tell you that this patient is having claw toes, charcoal joint, meaning this individual is, the leg has been susceptible to recurrent injury that is now leading to joint deformation because the person don't even know that is not landing on whatever it's supposed to land on. It's landing on sharp objects. But because it's not feeling the pain, they don't know. So there's recurrent joint destruction, causing the charcoal joint, in which you see the bones deviating in whatever angle. You can see the claws of the toes. They are having this clawing, claw toes, charcoal joint, and the reflexes are going to be absent, because it is your reflex that will help you with the sense of proprioception that, okay, this is where I should put my leg to maintain balance. They don't have all those things. The reflexes are gone. They don't feel any sensation. All the sensory impulses are gone. Proprioception, touch, pain, gone. They don't feel anything. So that should raise your suspicion for neuropathic ulcer. Then the last one is the pressure ulcer. We are going to classify pressure ulcer in step 2, but here we don't need to stress ourselves. Just know that it's very common in people with prolonged unrelieved pressure. People that are in ICU for a long time, they are not undergoing regular 2-hour turning, sitting in one place for a long time. People on wheelchair, pressure areas like maybe the sacrum, the ischium, the calcaneus in people that are lying in bed, the calcaneum, the heel. People having ulcers in all those kind of areas, this is likely to be pressure ulcers. So pain is there because it's related to ischemia, and they can have soft tissue infection, cellulitis, osteomyelitis, and the likes. So there's nothing really very serious about the ulcers. Let's check 1 or 2 questions and see. A 45-year-old woman comes to the physician because of 2-month history of painless wound on her right toe. She has not sought medical care in 5 years. She has a history of untreated hypertension. Temperature is normal. Pulse is okay. Respiration is good. Blood pressure is 160. Photograph of the lesion is shown. There is a diffuse hyperpigmentation of the anterior shin. Probe to bone testing of the lesion is negative. Sensation to pin prick and light touch is decreased over the sole of the feet bilaterally. The remainder of the examination shows no abnormality. Which of the following is the most likely cause of this patient foot lesion? So let me show us the lesion. So this is the lesion, right? Can we see it?
Yes.
Yes.
First of all, what area is this?
First metatarsal.
Yeah, you need like the metatarsal.
The base
Two.
of the
Right,
first.
the base.
The base of the first
Oh.
metatarsal. So what type of ulcer do we think that is from the history?
Neuropathic.
Neuropathic also.
Yeah. So somebody saying neuropathic ulcer. Why did you say it's neuropathic?
Because there is
less pain.
less sensation to pinprick
Exactly.
and light touch.
Because number 1, it is painless, and number
Painless.
2, sensation
Location.
is decreased everywhere. And number 3, the location is also a pressure area, which is the base of the first metatarsal. So what do we think out of this option? Which one can compromise nerve function? That's the next thing.
B.
Genetic also.
Good job. So
Yeah.
the
That's
doctor that said
diabetic.
B. So what's your diagnosis for B?
DM.
DM foot.
DM.
Fantastic.
Diabetic foot.
So A is going to be talking about which type of ulcer?
The venous ulcer.
Venous also.
So immune mediation, that's another thing entirely. Atherosclerotic occlusion of that's going to be arterial ulcer.
Arterial ulcer. Yes.
Bacterial inflammation of the bone marrow. What are these guys talking about? So that's that about the ulcer. So let's look at the miscellaneous disorders. The first is acanthosis nigricans. The doctor has already told us about acanthosis nigricans, earlier before. And what I just want us to know here is that this condition, we need to see the way it looks like. Number 1, do I have the image? Yeah, this is what it looks like. So You see this? Please, let's mute our mics. So we see this. Hello. So we see this lesion usually in the intratragenous area of the body, like the groin, the armpit, where you have all these skin folds. And they are going to have a smooth, the question might call it velvety appearance. So smooth hyperpigmentation, in the groin or in the neck or in the armpit. Once you are seeing something that looks like this is acanthosis nigrans. Now, how does it happen? It happens because of trophic effect of insulin. Now, that is why anything that can lead to insulin resistance will cause acanthosis nigricans. And what are these things? Diabetes type 2, obesity, Cushing syndrome, PCOS. One thing that is common to all these things is obesity. So that can lead to insulin resistance, and insulin will keep fighting. And it has been discovered that insulin has a trophic effect on the skin. So it, causes hyper, proliferation of the skin in those areas, impacting those discoloration. So everything is linked to insulin. So that's the insulin type. Why the one that is related to malignancy? It's more like a paraneoplastic manifestation of malignancy. So gastric adenocarcinoma can also cause acanthosis nigricans. What other paraneoplastic manifestation of GI adenocarcinoma did we talk about?
Lestrolazine.
Yeah.
Lestrolazine, which is what? What lesion?
Sudden appearance
Seborrheic
a lot of
keratosis.
seborrheic keratosis on
Exactly,
the
numerous appearance of seborrheic. Fantastic. So the next one is erythema nodosum. Now, this one is very simple. You don't even need to stress yourself. Once they tell you that the patient is having a painful lesion in the anterior shin and they are seeing nodular lesions, just go and pick erythema nodosum and move. It's basic. It's too basic. So once you are seeing something like this, nodular lesions like this, in the shin, that is painful. That is what you ask yourself, is it tender? Is it painful? And the question said, yes. Just pick erythema nodosum. It's very, very common in the anterior shin and it's painful. And they can ask you for the pathophysiology. They will want you to make the diagnosis. Then the next thing is they are testing the pathophysiology. So it is actually a paniculitis, meaning it is due to inflammation of the subcutaneous fat, not the dermis, not the epidermis, not the what's it called, the what's it called, the you get. So the inflammation is from the subcutaneous fat. So we have to pay attention to that. It is a paniculitis. Say it so many times. Paniculitis. It is a paniculitis, inflammation of the subcutaneous fat. And the cause, can be gotten from the word nodoso. So no. N-O. N means nothing. So in 60% of the case, it is idiopathic. Then the O, this O talks about use of oral contraceptives. So people that use OCPs, they can have it. D for the drugs. So people that use penicillins, people that use OCPs, just like we mentioned, people that use iodides, they can have it. So the S for sarcoidosis. You cannot go for that exam and not know that sarcoidosis can cause erythema nodosum. Sarcoidosis causes erythema nodosum. Don't forget that. The U is IBD, inflammatory bowel disease like ulcerative colitis. Ulcerative colitis can also cause erythema nodosum. Dr. Binde must have mentioned that. I know that. So even Crohn's disease is part of the extra-intestinal manifestation of those IBDs. Then the M is microbiology. So you think about chronic infections like tuberculosis, like leprosy, coccidioidomycosis, histoplasmosis, just like we have in our screen. They can cause erythema nodosum. So this acronym that I mentioned now is in step 2, but I could not find a way to smuggle it to the stuff. So let's take it again. N for idiopathic, O for the OCPs, D for the drugs, penicillins, OCPs, iodides, S for sarcoidosis, U for ulcerative colitis and Crohn's disease, M for the microbiology like strep, leprosy, histoplasmosis. Just think of any chronic infection.
Sorry, Dr. Babali, what did you call N?
N, no infection, nothing. Idiopathic.
Oh, okay, thank you.
Ichthyosis vulgaris. So this one is, you see, the one thing about this guy is that you don't have to be a genius to identify. Like, it's too conspicuous. Once you see it, you know that this is ichthyosis, because it just have this reticular appearance like this. You see, once you see this kind of pattern in somebody, this is ichthyosis vulgaris until otherwise proven. You know, and it has a reticular appearance. You can see that the lesion is very dry and scaly. That is ichthyosis vulgaris for you. It has the same pathophysiology like atopic dermatitis. So what gene did we say is affected in atopic dermatitis?
Filagreen.
So the filagreen is also mutated here,
Mhm.
and it's dry, because of desiccation, water loss. There's problem with keratinocyte desquamation, the shedding, so they accumulate there and they make the skin very rough. So it's just like somebody having old skin superimposed on new skin. That's the way it is, and it's very common in extensor surface of the body. So it has a strong association with atopic dermatitis. That's all about ichthyosis vulgaris. It's very straightforward. Then the next is lichen planus. You cannot joke with lichen planus. It is very high yield, and you have to know the 6 P's of. We usually shout this when I was in medical school. I remember there was one time I was asked this question. So what are the P's of lichen planus? So we have to know them. It's everywhere. Pyritic nature. It's purple. You know, ovulaceous in color. It is polygonal. It is planar. Purple plaque. So just like psoriasis, they form papules and plaques. But this one is flat, planar, flat. It is polygonal, so it has more than 3 sides, right? It is purple in color, and it is very, very pyritic. That's it. Once you see lichen planus, you know this is lichen planus here. We can see that because this guy's skin is black, so it might not really show us that purple stuff, but it's purplish. And we can see that it's flat. It has, like, it's polygonal in shape. It's flat, it is pyritic, and this is like a plaque. We have some small papules here, small one here, but most of them are plaques here. So it meets all the criteria of what's it called? Lichen planus. And what else do you need to know? So in addition to that, they can have involvement of the mucosa, and they have what you call the Wickham striae. So let me show you what Wickham striae is. Wickham striae is just like uh what's it called? Wickham striae is just more like reticular lines within the mucosa of the skin. So Wickham striae. So you look at the mucosa of the mouth, you'll be seeing reticular lines. This is lichen planus until otherwise proven. This is exactly. So you'll be seeing. So if they show you this in your exam, reticular lines in the mucosa, just know this is Wickham striae. Less like what reticular lines in the mucosa of the skin. That is in keeping with lichen planus and that one. You can't miss it. You can't miss it. And it's very classic. They usually have hypergranulosis, just what we have talked about. We have said this countless of time. And they come to war. Lichen planus are always planning war. You have a lot of lymphocytes gathering at the dermal epidermal junction, ready for war. They handle their sawtooth, their saw. They are ready to tear anybody apart. So you have a sawtooth infiltrate of lymphocytes at the dermal epidermal junction. So it's one of those histologic findings in lichen planus. And there's an association with hepatitis C. So a lot of associations of hepatitis C. Hepatitis C is implicated in lichen planus. Hepatitis C is in leucoclastic vasculitis. Dr. Babainde will have talked about that. Hepatitis C is in cryoglobulinemia, right? Hepatitis C is, I think that's the common stuff. Which infection is in polyarthritis nodosa? Anybody?
Hepatitis B virus.
Hepatitis B.
Very important stuff. So, pityriasis rosea is a nest, and um, this one is caused by a virus. It's caused by human herpes virus type 6 or type 7. So, type 6 or type 7, the roseola virus, causes pityriasis rosea. And how do they start? So, they'll just tell you in the question that somebody, a child, or an adult, like 20-year-old guy, start developing fever, low-grade fever, coughing, or not coughing, low-grade fever, sore throat, sneezing, rhinorrhea, and all those things, viral prodrome. And after a while, develops a patch somewhere in the body. That is what we call the Herald patch. So let me show you what the Herald patch looks like. This is the Herald patch. So they have this Herald patch with like scaly lesions on it, single erythematous lesion, anywhere in the body. Sometimes it is missed, right? Then after this Herald patch develops, they will now have crops of erythematous plaques developing in like a Christmas tree distribution. So it's moving like centrifugally. So you see something like this coming from up downward, spreading outwards like Christmas tree. So these, are the lesions of pityriasis rosea, and you notice that they're having a collarette of scale. It looks scaly, right? Can we see it?
Yes.
So
Yes.
that is what we expect. So we can see that it's coming like inverted V. It's coming downwards, upward, downwards, 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 downwards. So that is Christmas tree distribution of pityriasis rosea. So they've had a previous infection, human herpes virus type 6 or type 7. They have the Herald patch, and later they have this evolution of this rash. That's pityriasis rosea. It resolves on its own within 6 to 8 weeks. You don't need to do anything. Then the sunburn. Sunburn is very simple. Sunburn means you like there's burning of the skin, and it's due to exposure to ultraviolet rays. So type A and type B. Type A and type B. Now, UVB contains B, causes sunburn. UVA contains A, causes aging of the skin. So what are we talking about? Now, people with exposure to sun can get exposed to UVB, and they will have sunburn. And what will happen? UVB will cause breakage of DNA of keratinocytes, and when they break the DNA, they mutate the DNA of the keratinocytes. By the time we start talking about pathology, we'll talk about apoptosis. Whenever there is, destruction of the DNA of a cell, they arrange it for apoptosis straight up. That's the way the body maintains normalcy. So once you are damaged, you are gone. So there's DNA mutation, they are arranged for, scheduled for apoptosis, and they are taken out. So, that's the way sunburn destroys the tissue. And when you are taking out the keratinocytes, you are practically making the skin vulnerable to more injury. So they start having some generation of some free radicals too, which will lead to inflammatory response. And the inflammation is going to lead to redness of the skin. It's going to lead to tender skin, red skin. There could be swelling, like something that looks like inflammation. Sometimes it can be scaly in some occasions. So the skin is going to be like looking burnt, red, swollen, hot, tender, all those kind of things. So warm, tender, swollen skin. I think I have an image of sunburn, what it looks like. So it's due to the fact that you have loss of the keratinocytes, damaged keratinocytes from the injury, and from there you have generation of inflammatory cytokines to take care of those keratinocytes, and from there the inflammation destroys the normal tissue, and it starts happening this way. So you see the blisters, swelling. You see the erythematous area. You touch it, it's very tender. You feel it, it can be warm to touch sometimes. So that is sunburn, right, from UVB. Now, UVA causes much more bad damage because it penetrates deep, across the epidermis into the dermis, and in the dermis, you have a lot of collagen elastic fibers there. And what the UVA is going to be doing is it's going to be destroying those collagen elastic fibers. And we know that collagen and elastic fiber is what gives the skin its rigidity, its toughness, its elasticity, like that's dope appearance. Once you have destruction of the collagen, they start wrinkling, they start looking, rough and dry and, irregular. So just like a skin of somebody that is old. So that is what we call photoaging, and it's caused by UVA. So the skin appears dark and wrinkled, tanning and photoaging. Now, what do we mean? Just look at this image and compare them. So look at this man, sun protected, but when it's sun exposed, you can see the wrinkling, because you are losing the collagen, the elastic fiber. So that elasticity is reduced. So the skin cannot appear taut again. So it will be wrinkled. And this is photoaging from what? UVA. So sunburn increase the risk of skin cancer. So you don't want to have that. Albinism increase the risk of skin cancer. Okay. So let me see. I think I have questions here. A 10-year-old girl is brought to the physician by her mother because 10-day history of puberty crash. The mother reports that she initially noticed a single round lesion on the child's upper abdomen that gradually increased in size. Smaller lesions have since spread over the trunk, the neck, and both arms. The child also has fever, sore throat, malaise a week before the onset of the rash. The child and her family recently went for picnic in the woods around their house, but the mother does not recall seeing any ticks on the child. She has no significant past medical history and she does not take any medication. She has not received any vaccine because her parents believe that the risk of side effects are worse than the condition. The temperature is normal, pulse is okay, blood pressure is 960. Physical examination shows the finding in the photograph. Which of following is the most likely diagnosis? So let us look at the finding. But we have a spot diagnosis already. So what do we think?
Yeah.
Pituitary, yeah, because of the history. Pituitary rosacea. That
Exactly.
the history of the Herald patch.
Yeah, and what else? What else?
She had a prodrome before it started.
She had a prodrome, exactly. And from the image, we can also see the Herald patch. This is the Herald patch here. And we can see the crops of the, stuff.
Christmas tree.
Christmas tree. So that's pictures. Okay. And a previously healthy 24-year-old woman comes to the physician because of one-day history of painful rash after spending several hours in the sun. Skin examination shows well-demarcated areas of erythema with some scaling on the face, the chest, back, arms. The affected areas are hot, sensitive to touch. Oral mucosa appears normal, which of following is the most likely underlying mechanism of this patient's skin finding. That was fast.
That's what I think too.
What?
No, I think the apoptosis of keratinocytes in the epidermis.
That was very fast. Good job. Okay. So that is photoaging. Or what's our diagnosis?
Sunburn.
Sunburn.
UV. UVB.
Sunburn. Please don't fall for my trap. Don't fall for my trap. That's sunburn. Okay. Okay. I think we still have like. Do we want to go for breaks or we just push it 30 minutes more? Then we'll go for break. What do you want us to do? So that
We can go to break. Doc, I didn't get the last question.
Let's continue.
Hold it. I didn't
what?
get the last question, the answer.
The answer
You
is
don't mind.
the answer is apoptosis of the keratinocyte. This is sunburn. It means that the apoptosis, just like I explained, the keratinocytes are labeled for apoptosis,
Okay.
inflammatory response in response to the death of those keratinocytes. That's the reason why you have those burning.
Thank-
Okay, so let's just push it to 3:30.
Let's
Then
just finish.
okay, so I don't want people to get too tired because it's not easy. I know it's not easy because in as much as I want us to finish fast, I also want us to understand. That is a major stuff. So
Maybe like a 10-minute or 5.
Yeah, we can do a few minutes. Just sitting down and assimilation start getting low.
okay,
If we
okay. So
sit.
let's just do like 10 minutes break, and we'll come back by by 3:10 my own time.
Okay, thank you.
So we are going to continue with now talking about how we estimate the body surface area. So this is very important. We use the rule of 9. That's the simplest one that I know, and we can use that to estimate the extent of burn injury. Also in people's the TN and SGS, you can also use that one to also estimate the percentage surface area of the skin that is affected, so you can know whether to classify it as SGS or as TN or as SGS TN syndrome. And before that, there's something we should talk about, which is inhalation and injury. So we'll talk about this more in step 2, right? But this is just a problem that happened in somebody that is confined in a space and the person is exposed to a lot of fumes, a lot of smoke. That's major cause of inhalation and injury. And the person inhales the heat, the particulate matter, irritants like ammonia, everything suspended in the smoke. And it could lead to some chemical irritation of the airway, causing like chemical tracheobronchitis, causing edema of the airway. It could cause like pneumonia, chemical pneumonia, aspiration pneumonia, depending on the severity. They could have ARDS, like within like 24 hours, after 24 hours. They can have some other manifestations. So depending on the situation, they could have carbon monoxide poisoning, and all the methemoglonemia, and all those things. So, sorry, I didn't say methemoglonemia, carbon monoxide poisoning or cyanide poisoning. So, depends on the case. Now, one thing we usually look out for, particularly with respect to step 2 that talks about inhalation injury, is that you observe the nose. And once you are seeing singe nasal hair, meaning you notice that the nasal hairs they appear burnt. That's what you call singe nasal hair. Or you look at the oropharynx, you open it, you are seeing soot. You are seeing carbonaceous sputum. You know that this individual is already having inhalational injury. And the next thing you want to do anywhere in the world is to intubate that patient. If you delay intubation and you are giving fluid, the fluid is going to worsen the edema, and the person is going to eventually die of laryngeal edema of the larynx. So you want to stop your fluid and intubate, secure the airway first before you start resuscitating with, fluid. Very important stuff. So by the time you are seeing singe nasal hair, you are seeing carbonation sputum, you are seeing soot in the airway, in the mouth, just intubate that patient immediately. So if you do your bronchoscopy, you can see severe edema, just like what we have in image A, that is everything is just clumsy, congestion, and soot deposition. Yeah. So how do we estimate the body surface area? Well, how do we do it? So we use the rule of 9. So what we just need to know is that the head and the upper limb, they take 4.5. So they are the ones that are cheated. We cheat the head and the upper limb. So we give them 4.9, 4.5 instead of 9. Why the other part of the body is going to be 9. So, but we also need to know that we have to divide the belly or the upper like the upper body into the chest and the abdomen. So chest is a compartment of its own, so it takes 9. The abdomen is a compartment of its own, it takes 9. So know that the 9 that the chest is taking is front and back. So front 9, back 9. The belly too, the abdomen, front 9, back 9. Then for the lower extremity, front and back 9, 9 each. So front part of anterior aspect of the lower extremity 9, the posterior aspect 9. Same for the second leg 9, 9. Just like we have in the image. I give you a perineum 1. So that is it. Front of the head 4.5, back of the head 4.5, front of the upper limbs 4.5, back of the upper limbs 4.5, front of the chest 9, front of the back 9, back of the chest 9, back of the abdomen 9, and the legs. So I think that is clear to us. Is it clear from the image? Do we understand it?
Yes.
Yeah. So now to now use it, so they can tell us that an individual is having injury to the head, bone injury to the head. We don't need to know if it's all the head. Once the head is involved, you give the person 4.5. So if they tell us front and back of the head, so that's going to be 4.5 plus 4.5, 9. So if they tell us anterior aspect of the upper limb, right upper limb, 4.5. If they tell us the entire leg, the entire lower leg, the entire right leg, that's 9 plus 9, that's 18. If they tell us entire both legs, that is front and back of both legs, that is 18 plus 18, that's 36. It's as simple as that. So, how do we classify bonds? This is very easy. Like, it is too simple, and we can classify, bonds into like superficial bond, deep bond, full thickness bond, deeper injury bond. So we have superficial bond, and after superficial bond, we have like partial thickness bond. Now we further subclassify partial thickness into superficial and deep. So superficial bond, partial thickness bond, which can be subclassified into superficial and deep. And we have the full thickness bond, then we have the deeper injury bond. Now, the first thing I usually mention before I start is that superficial bond and superficial thickness bond, one thing that is common to them is that there is pain. So if anybody have any form of superficial bond, this bond is just superficial now. Don't worry. It's just small pain. It will go. All superficial bond are painful. All partial bond are blisterous. So once there's a word partial in the bond, there is going to be blister with it. Once there's partial with the bond, there's going to be blister. But once it's superficial, it's going to be painful. Once you know this rule, you are okay. That's all. So the first classification is the superficial bond. The skin, the part of the skin that is involved is only the epidermis. Only the epidermis. And what happens? You just notice that area is red, erythematous. It's just like somebody having a sunburn, but there is no blister. There is no blister. I've said it. The only area where you have blister is when you have a partial burn. Once there's a partial burn, there will be blister. But superficial burn is not partial burn. So there's no blister. The only thing you see is area of erythema. And because it's a superficial burn, it's going to be painful. That's all. You are done. The next is to go to superficial partial thickness. Now, this one is involving the epidermis as well as the papillary dermis, because we have two types of dermis, the papillary dermis and the reticular dermis. Reticular dermis is deeper than papillary dermis, right? So superficial partial thickness bond means that it has extended into the dermis. So it's involving the epidermis and the papillary dermis. It is a partial bond, so there's going to be blisters. It is a superficial bond, it's going to be painful. You are done. The next is to go to deep partial thickness bond. Deep partial thickness bond, meaning the bond has gone beyond the papillary dermis and it has extended to the reticular dermis. But mind you, it has not involved the entire thickness of the reticular dermis. It's just extending to the reticular dermis. Deep partial thickness bond. You can always arrange it like that in your head. Don't miss any step. Superficial partial thickness, deep partial thickness, full thickness, deeper injury. So what happens in deep partial thickness? This is a partial burn. There's going to be blisters, but it is a deep burn, not superficial. So it's not going to be painful. So because all the nociceptive nerve endings are going to be taken out, they are going to be burnt. So there's nothing to confer the pain sensation. The best they can have is pressure. But you don't need to be looking for pressure. You just need to know, is it painful or not painful? So once it's not painful, you know that this is actually a deep burn. It's painless. As a partial thickness burn, there's going to be blisters, right? The next is a full thickness burn. It means that the burn has extended beyond that reticular dermis. It has taken the entire part of the reticular dermis. That is your full thickness burn. And the appearance now is that because it is no longer a partial thickness burn, so, and we have said that one thing about partial thickness burn is that they have blisters. So this one doesn't have any blister. They will look whitish, they look waxy, they look leathery in a last. By the time the question is describing all these things, you know that this is actually beyond partial thickness. It is a full thickness or beyond. So white, leathery, blah, blah, blah. And of course, it's going to be painless. Then the last one is deeper injury burn. It's very similar to full thickness. It means you have now gotten to bone, you are seeing muscle, you are seeing, facial and all those things. Same thing is going to be white, leathery, elastic, blah, 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 and it's going to be painless. So the first thing is just to ask yourself, what layer is affected? Epidermis, superficial? Is it getting to the papillary dermis? Yes. So that's superficial partial thickness. Is it getting to the reticular dermis? Yes. So that is deep partial thickness. Is it involving the entire part of the reticular dermis? Yes. So that is a full thickness. Is it getting to the muscle, the bone, the fascia? Yeah, that is a deeper injury. So is it painless or is it painful? Yeah, it's painful. So that's a superficial burn. So it must contain superficial in its nomenclature. Is it blisters? Do you have blisters there? Yes. So once there's blister, it's going to be a partial thickness burn. So either superficial partial thickness or deep partial thickness because it's blisterous. So, but if it's only a superficial burn, it is only painful, there's no blister. You just see area of erythema. That is all. Do we understand this algorithm?
But please, how do you
Yes.
differentiate the full thickness and the deep injury on appearance?
So the deeper injury, you are going to be seeing bone. But you see somebody that is burnt and you are seeing bone. That is deeper injury. You are seeing muscle. That is deeper injury. Do you understand, doctor?
Yes.
So
Thank you.
that is that. So if we say
Okay.
we understand, then let me ask us a question now. So a 35-year-old man is brought to the emergency department 40 minutes after spilling hot oil on himself in the kitchen. Examination shows multiple tense blister over the abdomen, anterior chest, entire right leg. The roofing of the blisters reveals tender, mottled underlying skin that does not blanch with pressure. Examination of the left eye shows tender erythematous skin with quick capillary refill, blanching with pressure. Which of following is the closest estimate of the total body surface area affected by the second degree burn in this patient? So, what do we get? Anybody?
Wait. It says the left eye.
Maybe 36? I'm not too sure.
That's very correct. So, how did you get the 36?
Mm,
Okay, so for the entire, okay, I'll start with the abdomen, which is 9. The anterior chest is also 9. And then the entire right leg, which is 18. So I added all of them together.
Thank you. That's very correct. Good job. A 44-year-old man is brought to the emergency department
So
by.
sorry, sir, excuse me.
Okay.
So
There's
I
also
can see
involvement of
from
the
the
right.
question, so that the which leg is that? The left leg is not included because it's a superficial bone.
The left leg. No, they said entire
Yeah,
Yes,
they
right
there's
leg.
say
involvement of the left leg.
yeah.
Sorry, they didn't mention left leg yet.
They did.
Left thigh,
Left
sorry,
eye.
Examination
sorry,
of the
left
left
thigh.
eye.
Okay,
During the
examination of the.
continuation.
Okay, yeah.
Yeah.
So, which of the following is closest male with total body affected by the second degree injury? So that is why. So
Okay,
that left eye is just
Second degree.
a first degree one, yeah. So that's why.
okay.
Thank you for calling my
Doctor,
attention to that.
So what's the answer then?
So 36 is correct because you will not
Still
include the left eye.
the left eye.
Dr. Babawale, I have a question. From the question we have, they specified that the chest was anterior and they specified the anterior right leg. But when it came to the abdomen, they didn't really specify whether it's anterior or posterior or both. So I assumed that since they just said abdomen, it was both anterior and posterior.
So you will not get
So
45,
I
right?
used 18 for the abdomen,
18 for
Yeah.
the abdomen.
and then
So
9 for the chest and
9
18
for
for the right leg.
yeah. So
for
I
the
know
right
So I
because
just wanted to clarify that.
yeah. So the question is very valid actually, but I don't think they would actually they would just say the back, maybe upper back or lower back. Do you understand? So because the I don't think they would use the word posterior abdomen. Me, I just said it just for us to be able to see what I'm trying to describe. That was why I was saying front and back, anterior, posterior. In the question, they might not say that posterior abdomen. We don't have posterior abdomen. Like, how do I say it? Like, abdomen is like, like if you say touch your abdomen, you
It's more
most likely
fun.
touch your
Okay.
front. So
The
that's it.
front. Okay.
Yeah, yeah.
All right.
So, but
Thank you.
hopefully in our exam, the portion would be well delineated. Some of these question bank can be clumsy at times. Yeah.
Okay.
So a 44-year-old man is brought to the emergency department by a co-worker 2 hours after accidentally burning his foot on an electric grill that he keeps next to his bed because he likes to wake up to the smell of bacon. He initially decided to go to work despite his injury, but felt it was too serious to ignore. He's the regional management of a paper company. The vitals are okay. Examination of the right foot shows erythematous skin with multiple blisters, some of which have ruptured. The um the the affected skin is tender to touch. Which of following describes the skin findings? Anybody wants to help us?
Superficial partial
Superficial
The
thickness.
partial.
superficial partial bone, thickness bone.
Okay, please, 1 minute. I'm coming. Okay, yeah. So what did we say?
Superficial partial
Superficial
thickness.
partial
Superficial
thickness
partial
bone.
thickness bone. Why? Why are we picking that?
Because there is blisters and also there is pain.
Painful.
Because there is
Mhm.
blister and there is pain. It's very simple. So that's the way it works. So the superficial bone is the first degree bone. The partial thickness bones, they are the second degree. The full thickness bone is third degree. Deeper injury bone is fourth degree. Do we understand that?
Okay,
No,
go
can
again.
you come over
Can you
that
say it
again,
again?
please?
Superficial bone is
Mm-hmm.
first degree.
Okay.
The partial thickness bone, both of them, superficial and deep, second degree, right? The foot thickness burn is 3rd degree. The deeper injury is 4th degree. Do we get it now?
Mm-hmm.
Yes.
Yes.
So moving on to the last part, we still have the medication. So the skin cancers, very easy. 3 major cancers. The first is the basal cell carcinoma. And most of the time, basal cell carcinoma occurs above the lips. It's the commonest skin cancer, but I want to tell us that basal cell carcinoma is the only malignant cancer that rarely metastasizes. I don't know why, but indolent in a way. And what do you need to look out for to identify basal cell carcinoma? Number one risk factor is sun exposure. So basically, you are going to be seeing these lesions in the face most of the time. And what typical lesions are you looking out for? You are looking out for shiny lesions, pearly nodules that are shiny. And if they want to help us, they will tell us that they are telangiectasias. By the time you are seeing telangiectasia with row borders, just go and pick your basal cell carcinoma. So let me show you what we can see. These nodular pearly lesions, rolled up borders that is shiny. This is classic for basal cell carcinoma. You can see it's very close to the eye. This is affecting the face. This is the way it looks like. Once you are seeing telangiectasias, row borders, pearly nodules, which is shiny, basal cell carcinoma, basal cell carcinoma. You can also have some other types. Hello? Hello? Let's mute our mics, please. You can also have another form that is, scaly plaque, having scaly plaque. So it's not very common that they will test this because it might be difficult to identify. So, but you can have superficial basal cell carcinoma that can appear like this. But most of the ones that they will be tested, that you'll be tested on would appear like this, having this nodular, shiny, pear-like, configuration with rolled up borders, basal cell carcinoma. Now, the risk factor is what? Don't forget sun exposure. Sun exposure is the commonest cause of skin cancer. The next one is the squamous cell carcinoma of the skin. Now, this one looks like injury, like as if somebody has a chronic wound. You'll be seeing hyperkeratosis, scaliness, and all those things. So something like this, and it's the second most common. So squamous cell carcinoma of the skin follows immunosuppression. So people with HIV, people with suppression of the immune system from anything, people with chronic non-healing wounds can develop what we call marjoling ulcer. So people that have wounds that is not healing for like 20 years, they can have eventual malignant transformation, and you call that a marjoling ulcer. So a marjoling ulcer is a type of squamous cell carcinoma of the skin, So sun exposure, immunosuppression, chronic non-healing wounds, exposure to arsenic, all of them are risk factors for squamous cell carcinoma. Now, if you look at this doesn't look like there's some healing happening here or like wound. But if you look at this, you can see the keratotic debris, the crusting, occurring here. So that tells you that this is like the squamous cell carcinoma of the skin. So if you do your biopsy, you are going to be seeing keratin pairs because squamous cells, epithelial cells, they produce keratin. So they have the keratin. Even if you are talking about squamous cell carcinoma of the lungs, all those keratin pairs too is there. So anything squamous, just think of keratin, And if you do your biopsy of your basal cell carcinoma, you are just going to be seeing basaloid cells. That's it, basaloid cells. Here, we are going to be seeing keratin pairs. There's another pre-malignant form of squamous cell carcinoma that I call actinic keratosis. You have to have this at the back of your mind. Very important. And what does it look like? This is actinic keratosis. This is not very classic. Let me look for one online. Actinic keratosis is like a pre-malignant form of basal cell carcinoma, of squamous cell carcinoma rather. You see it at the sun exposed area, like the head, the face, and it's going to appear rough, scaly. We are seeing rough, scaly erythematous lesion in the head. The face, just know that this is actinic keratosis. You can see this lesion here. Erythematous background with a scaly, rough. Exactly. This is the way it looks like. Actinic keratosis. So it's a precursor lesion to squamous cell carcinoma of the skin. Very, very important. Scaly, rough, erythematous lesion on the head, the face. You want to rule out actinic keratosis. So there's a risk of squamous cell carcinoma depending on the degree of the epithelial dysplasia. So it's a form of dysplasia, actinic keratosis. Don't forget that. Moving on to melanoma. Melanoma is well tested. You like it. You have to know it. It's a tumor of the melanocytes. Melanocytes are derived from the neural crest cells. The tumor marker of the neural crest, derivative is S100. X100 is bad. So one of the tumor markers is S100. Don't forget that. It can occur from dysplastic nevus. I talked about some background precursor lesion. Anybody remembers? I just want to know. Can anybody remember what we said can lead to melanoma? Anybody remembers? Okay, I know. So it was
Effective, sorry.
UVB.
the what?
UVB.
HBV.
No.
The
It's not
junctional nerve.
ultraviolet with B. UVB.
The melanocytic nevi is like
Oh,
a benign
melanin.
form.
Sorry.
Exactly.
Cancer.
So
Yeah.
when we're talking about those melanocytic nevi, so I talked about the atypical one, and I talked about the congenital one, and I talked about the acquired one. So I said that when I was talking about the junctional, the compound, the intradermal, those ones are the acquired one, and they have a low risk of differentiating into melanoma. But the ones that can go into melanoma easily is the atypical one, as well as the congenital nevi. We mentioned it. So, and another name for the atypical nevi is the dysplastic nevi. So it's actually with a high risk of malignant transformation to melanoma. People with light skin, they have so many problems. Melanoma is one of them too. And there's something we must remember, which we call the breast lobe thickness. So the breast lobe thickness correlates with the risk of metastasis. And when we say breast lobe thickness, it means we're talking about the depth of the tumor. How far has this tumor gone vertically, not horizontally? How far has this tumor gone vertically? How deep has it entered into the tissue? A melanoma that has gotten to the dermis and a melanoma that has gotten into the subcutaneous tissue, which one do we think has a more risk of metastasis? Anybody?
So cute.
Yeah, the one that is deep into the subcute, because the breast lobe thickness of that one is more vertically, So the deeper you go, the more the risk of metastasis. That's what we call the breast lobe thickness. The breast lobe thickness. It measures the depth of the tumor. Don't forget that. How do you identify melanoma? ABCDE criteria. A for asymmetry. Now, this is a melanoma. Image G is a melanoma. Once you see something like this, it doesn't know that this is melanoma because it meets all the ABCDE criteria. This tumor is asymmetric. If I divide it into half, I cannot divide it into two equal halves. It is not possible. If I'm dividing it here, this will only contain the pigmented part. This is the non-pigmented. So it's not a two equal half. Asymmetric. B, for the border irregularity. You can see that this border is not regular, right? C, for the color variegation. You can see that there's hyperpigmented area, hypopigmented area. The D, for the diameter. The diameter is usually more than 6 millimeters. I did not say 6 centimeter, please. 6 millimeter. Then the E is evolution with time. So with time, you notice changes in the border, changes in the color, changes in the appearance. Classic for melanoma. ABCD, asymmetric, border irregularity for the B. The C, color variation. The D, diameter more than 6 millimeter, and E, evolution over time. So before you can make diagnosis of melanoma, it has to meet your ABCD criteria. So there are 4 types. We don't need to bother ourselves. The superficial spreading, the nodular, the lentigo maligna, and the acral lentiginous. So the one that is very common in people that are dark is the acral lentiginous. Very common in dark people. Acral lentiginous. It starts from the legs. See it like this. Some people will see something like this and they will be like, I just blood in the kidney. This is melanoma, and it can spread to the brain, can go to the lung. It's very bad. It's killed one popular musician like that. Melanoma is dangerous. So, the commonest one is the superficial spreading. It just spreads superficially. That's the commonest one. You have the nodular one. That one is just going like a nodule. We also have the lentigo maligna and the acral. So we should not worry yourself about that. Just know the types. And what drives it? The BRAF kinase mutation. You cannot forget this. There's no way you can forget this. It's not acceptable. You have to be talking about this. Anytime you're asked, tell me about melanoma, you have to mention this. The BRAF mutation is implicated. Anybody remembers any malignant, any tumor that the BRAF is involved? Anybody?
Papillary thyroid cancer,
Papillary thyroid cancer, very correct. What else?
hairy cell leukemia.
Hairy cell leukemia. This doctor is fantastic. So that's the way it works. So how do you treat? You just have to exercise with appropriate margin. Make sure you have like 5 millimeter to 6 millimeter margin that is free of the cancer. You exercise. Surgical is very basic. Don't stress yourself. Surgical excision. If it's advanced, you might give your BRAF inhibitors like your vemurafenib or your ipilimumab. We are going to talk more about ipilimumab by the time we do immunology. So it's one of those checkpoint inhibitors. Dr. Fessor is going to go to town with that one. So don't forget your BRAF mutation. Don't forget the S100 marker. Don't forget the types. Don't forget the ABCDA criteria. Never forget the breast load thickness. Not acceptable. Very, very important stuff, right? This is, the melanoma again already, So moving on to the drugs for MSS, for skin. And so we are going to be starting with the anti-inflammatory agents. And a very good example is our steroids. And what the steroid does is to activate inhibitor of KB. And when they activate inhibitor of KB, they inactivate nuclear factor for KB. And when you inactivate nuclear factor for KB, you inactivate your COX. So just let's keep that pathway like that. I'll come back to it. But let's just know that we have so many things that drive inflammation. We have our prostaglandins, we have our leukotrienes. And the old synthesis of our leukotrienes or prostaglandin, which are inflammatory mediators, start from the membrane lipids, the membrane phospholipids. And from the name, we need something to act on the phospholipids to convert it into arachidonic acid. And that's where our phospholipase A2 comes in. Phospholipase, taking it to A2. So phospholipase will convert phospholipid to A2, which is arachidonic acid. Very simple. Arachidonic acid will now start differentiating depending on the pathway. So if we want to take arachidonic acid to leukotriene, our lipooxygenase is going to come in, act on the arachidonic acid, and convert it to our leukotrienes, which includes leukotriene B4, C4, D4, E4. So the C4, D4, E4 are called the slow reactive substance of anaphylaxis. So they are there to be driving anaphylactic, reactions to constrict the bronchial and be causing bronchoconstriction and all those things. That's about C4, D4, and E4. They work together. The only one that is distinct to them is the B4. And B4 is chemotactic. That is, B4 attracts neutrophils. B4 attracts neutrophils. The C4, D4, E4, they drive anaphylaxis. They also helps in bronchial constriction. So that is that about leukotrienes. Now, coming back to the arachidonic acid, it can also go to form prostaglandins, right? And instead of lipooxygenase acting on the arachidonic acid, it is not going to be lipooxygenase. It's going to be cyclooxygenase. So cyclooxygenase is going to form our prostaglandin, which includes PGE1, PGE2, PGF2 alpha, thromboxane, and even our prostacyclin. The only one I like here, although I like everything because everything works for us, but I have like affection for prostacyclin. It appears like a good guy, but can be dangerous too. So prostacyclin is also called PGI2. It vasodilates by relaxing the vascular tone. It also inhibits platelet aggregation. An example of PGI2 is epoprostenol. Epoprostenol is a PGI2. Epoprostenol. We have the other prostaglandin, PGE1, PGE2, and the PGF2 alpha. So all the ones with the two, they can constrict the uterus, and you can use them to stimulate labor. So the PGE1 reduce the vascular tone too. An example is apopostadil. Epoprostenol, apopostadil, dinoprostone, carboprost. So let's take them one by one. So the PGI2 is epoprostenol. The PGE2 is apopostadil. Apostadil. That's PGE1. The PGE2 is dinoprostone. Dinoprostone is PGE2. And the PGF2 alpha is carboprost. The one that I know is very easy to remember is the PGF2 carboprost. The PGI2 that I like is the epoprostenol. It's very good. So PGE1 is apostadil and PGE2 is dinoprostone. And also thromboxane can also come from cyclooxygenase, and they form the thromboxane that help in platelet aggregation and vasoconstriction. But the ones that are directly opposite to the thromboxane is the PGI2. Example, epoprostenol. They inhibit platelet aggregation. They also vasodilate. Now, we have seen the two pathways. Now, how can we modulate these pathways? So, you can give a 5-lipoxygenase inhibitor to block conversion of arachidonic acid to the leukotriene. And that's an example of a drug called Xylitol. Xylitol is useful in which condition? I'm sure we are familiar with this. Anybody? Asthma. So, if you don't want to block leukotriene, but you want to block their receptor, so you can give leukotriene receptor antagonist that's going to prevent this guy from achieving bronchoconstriction in asthma. So you can block their receptors, and that's like montelukast and zivalucast. So they are leukotriene receptor antagonists. Okay. Can we give a drug that would inhibit this entire process? No leukotrienes, no prostaglandin, no prostacyclin, no thromboxane. Yes. What drug is that? Glucocorticoid.
Corticoids.
What are they going to do? They are going to block phospholipase A2, number one. They would also activate inhibitor of KB. When they activate inhibitor of KB will go and inhibit KB because that's what it does. It is an inhibitor of KB. So it inhibits nuclear factor KB, and there is nothing to activate the cyclooxygenase again. So when cyclooxygenase is down, you can no longer synthesize your prostaglandin again, and the entire process shuts down. Glucocorticoids. Okay. Can you do some targeted, affectation? Yeah. I want to block COX-2. Now, I have to mention that the pathway for production of prostacyclin involve COX-2. COX-2 is a type of cyclooxygenase that acts on arachidonic acid forming prostacyclin, COX-2. So that means that if I give a drug that's selective for COX-2 only, example, celecoxib, I cannot form prostaglandin. I cannot form prostacyclin anymore. So that means that the action of the thromboxane is going to be unopposed, right? And the person is going to be having increased platelet aggregation and vasoconstriction. So that means that this person is at risk of MI. stroke, right? So you have to be careful in people you give COX-2 inhibitor. But you want to ask yourself, why do we want to give somebody a COX-2 inhibitor? Yeah, we might want to give somebody COX-2 inhibitor because we don't want to
Peptic
block,
the disease.
yeah, we don't want to block COX-1, because if you block COX-1, you will not be able to synthesize your PGE1, your PGE2, and your PGF2 alpha. And one of the functions of your PGE1 and your PGE2 is that they can help maintain blood flow to the gastric mucosa, preventing peptic ulcer. They can help vasodilate the efferent artery of the renal vessels to maintain perfusion to the kidneys, preventing renal ischemia. So that means that if somebody has the COX-1 off, they will not be able to synthesize PGE1, PGE2. The kidneys can shut down. The stomach can also be susceptible to peptic ulcer damage. So that's why we might want to give COX-2 selective inhibitor. But that can be detrimental too, because you can have increased platelet aggregation, vasoconstriction, leading to stroke, thrombosis, and the other complications. So what about the COX-1 inhibitors? Yeah, we have COX-1 inhibitors, but we don't have selective COX-1 inhibitor. All the inhibitors we have inhibit both COX-1 and COX-2. But the only difference in them is that one inhibits both of them irreversibly. So that means that if you give that drug, it will irreversibly inhibit COX-1 and COX-2. And the only way you can recover from the effect of that drug is when new platelets are synthesized, or when the new tissues are synthesized. That is it. While the other ones can inhibit reversibly. So the one that inhibits COX-1 and 2 irreversibly is aspirin. The other NSAIDs, they inhibit reversibly. So PGI1, EPO, Prostenol. I like PGI1 a lot, PGI2 rather. Then PGE1 is what apopostadil, PGE2 is the dinoprost, and the PGF2 alpha is the carboprost. So moving on to acetaminophen. So
Sorry, Dr. Babakwe.
Mhm. I
Sorry,
can hear
what
you.
did you say about inhibiting only COX-2?
So I said if you inhibit only COX-2, this person is going to have problem with platelet aggregation, right? That means that the person cannot reduce platelet aggregation again, right? So that means the action of thromboxane is going to be elevated. You know that what COX-2 does is to produce prostacyclin. Do you understand?
Hmm.
And
Yes.
prostacyclin is there to reduce platelet aggregation. So it means that if you don't have prostacyclin anymore, the activity of thromboxane will be activated and you have increased platelet aggregation. So that means that the person is going to be throwing clots. Do you understand?
Yes.
So that's why it's risky. You don't give people with stroke, MI, celecoxib. You have person has, you're just adding salt to the injury. So that's because of the risk of clot. Yeah. So
Doc, I
moving.
have a question. So
Okay.
COX-2 work only on prostacyclin.
Yes.
So if you inhibit that, will prostaglandin and thromboxane pathway be open?
Yes, because their own pathway is from COX-1,
Okay.
so it will be open.
So now, if you inhibit if COX-1 is active, it will inhibit prostaglandin and thromboxane pathway, and prostacyclin pathway will be open.
Yes. So, but you
Or
don't
does
have, but you
COX-1
don't
work
have,
on three of them?
but you don't have a drug that is selective for COX-1 alone. No, you don't have any drug like that. You only have a drug
So,
that is selective for COX-2 alone.
okay. So COX-1 work on all three of them, all the cyclooxygenase.
Okay, let me take it again. I think there's a confusion somewhere. So, we have three: cyclin,
Mm-hmm,
prostaglandins, and thromboxane.
mm-hmm, mm-hmm.
Now, what forms the prostacyclin is COX-2.
Okay.
What forms the prostaglandin and thromboxane is COX-1.
Okay.
You have a selective COX-2 inhibitor, meaning that you can inhibit only production of prostacyclin. Do you understand that? But
Mm-hmm.
in that situation, you have unopposed activity of your COX-1, so producing a lot of thromboxane. And thromboxane can increase platelet aggregation, causing
Mm-hmm.
clots.
Okay.
Because why am I saying that? Because the activity of prostacyclin is balanced with thromboxane. You see that both of them, they do exact opposite action.
Okay. Mm-hmm.
So that means that if you are taking out your prostacyclin, thromboxane is happy, and thromboxane will be forming platelets, aggregation, and vasoconstricting the vessel, leading to clot formation.
Okay.
Now,
While prostaglandin opposes it, so do we still have to have um, a blood clot if we have prostaglandin vasodilating it?
so no,
Oppose that action.
because the effect of thromboxane is going to outweigh what your
Okay.
prostaglandin would do. Because
Okay.
the only thing your prostaglandin is doing here is just to reduce the vascular tone. Yeah, fine. But your thromboxane can increase vascular tone and at the same time can increase platelet aggregation.
Platelet aggregation. Okay.
So
Okay.
that is why it's going to surmount your prostaglandin. Yeah.
Okay.
So acetaminophen is a drug that we all know, paracetamol. It reversibly inhibits cyclooxygenase. So just like the NSAID, it inhibits cyclooxygenase, but it works in the CNS only. So meaning that it can only work centrally. Once paracetamol is still within the peripheral circulation, it is metabolized. It doesn't work peripherally, it works centrally. So it's being mopped up by the liver, metabolized, excreted, that's all. So it has only antipyretic and analgesic action. Paracetamol does not have any anti-inflammatory action. I'm sure we all know that we don't give paracetamol for inflammation. So we only give it headache, pain and fever. That is it. But we use it in some situation. For example, if you don't want to use aspirin in a baby that has influenza or varicella, you don't want to give aspirin because you want to avoid Reye syndrome, which I'm sure Dr. Abande will have told us. So instead of giving aspirin to somebody that has a potential for developing Reye syndrome, give your acetaminophen. But it has no inflammatory role, no anti-inflammatory role. So overdose of acetaminophen, we talk more about this in step 2, and it can cause hepatic necrosis. But for step 1, we need to know the metabolic pathway for this acetaminophen, what is being produced, how it happens, and how you can correct it. That one is not step 2 stuff. It is basic step 1 stuff. And I'm going to talk about it in the pathology discussion. So once you take more than 20 tablets, hepatic necrosis happens. The acetaminophen is metabolized by the liver, causing production of NAPQI. NAPQI is a free radical, and it mops off all the glutathione. Glutathione is an antioxidant which mops off free radical, but it will get to a level that the level of the free radical, which is a NAPQI, is going to surmount whatever reserves of glutathione that the liver have. So once all the glutathione is taken off, NAPQI is attacking the liver directly, causing hepatic necrosis. Can be very bad. Can lead to acute, hepatitis, fulminant liver failure, and the person will need definitely a liver transplant. So, what we do to treat these overdoses is that we quickly give N-acetylcysteine, and when you give that, it will replenish the hepatic stores of the glutathione, which is going to help us mop up the NAPQI. That is what N-acetylcysteine does in treatment of acetaminophen toxicity. Aspirin, just like I've said, aspirin irreversibly inhibits COX-1 and 2 by covalent acetylation. So once COX-1 and 2 is taken care of, it means you can no longer form thromboxane, you cannot form prostaglandin, you cannot form prostacyclin. The thing is, prostacyclin is a type of prostaglandin. The only reason why they delineated it is because of the different function it plays from other prostaglandin. So when you you give somebody aspirin, and there's inhibition of prostaglandin, thromboxane, there's going to be prolonged bleeding time. Why? Because your thromboxane is gone, you cannot form clots again, and you cannot form platelet plugs again, and it's going to take a long time for bleeding, to stop. I think normal bleeding time should be like maybe 3 to 10 minutes or so, but it's going to be prolonged because of the cessation of platelet action. Mind you, it is only aspirin that has antiplatelet activity. Please note it. The other NSAIDs, they don't have any antiplatelet activity. Don't make that mistake. Aspirin will not have any effect on PT or PPTT. Who knows why? Anybody? Why? Why does aspirin not have any effect on PTT and PTTT? From what Dr.
You
Babalola...
just
I'm with you. Somebody wants to say something. Okay. The reason why aspirin will not have effect... I'm listening.
No, I'm saying is it neither neither goes through intrinsic or extrinsic pathway, but the reason I still don't know.
So the reason is because aspirin is an antiplatelet. Your PT and your PPT is only for what? For clotting factors. Your platelet is a scaffold for your clotting factors to come in. They are different things entirely. So if there's problem with the platelets, von Willebrand factor issues, aspirin use, there's going to be prolonged bleeding time. If there's a problem with the clotting factors, then you now start talking about PT and the PPT. But does aspirin affect clotting factors? No. So there is normal PT and the PTT. Okay? So the effect will last until new platelets are produced, right? Because it will have inhibit the production of thromboxane by these platelets. So they cannot do their function. So you need new platelets to form, that are not covalently acetylated by aspirin. So what's the clinical use? Depending on the dose, if you start like less than 300 microgram per day, you can use it, that dose, as antiplatelet 1. You give the maximal dose for anti-inflammatory, which is about 2004 to 4000. Then between 300 to 2004 is the one for the antipyretic and the analgesic. So this is not usually high yield, but it's good to know the dose. But we have to be familiar with the adverse effect of aspirin. Very, very important. You cannot go to that exam and not be able to identify toxic effect of aspirin. It's dangerous. So aspirin inhibits prostaglandin. We have said it that prostaglandin E2, I2, they help to maintain perfusion to the gastric mucosa and the kidneys, so preventing gastric ulcer. So that means that if aspirin is being used, prostaglandin synthesis is stopped, there's tendency of gastric ulcer, there's tendency of renal failure, AKI, right? Commonly, it can affect the vestibulocochlear nerve, causing tinnitus. You see a patient having tinnitus and you are not thinking of aspirin overdose. That's dangerous. That is very dangerous. Ringing sensation in the ear, gastric ulcer, abdominal pain, AKI, aspirin toxicity. Aspirin can cause interstitial nephritis. Have we done renal?
Yes.
We've done renal. So
Yes.
what are the common drugs that can cause interstitial nephritis?
Aspirin,
NSAID,
lithium.
Statins, penicillin.
Yeah, so sulfonamide, beta lactams, NSAIDs, all those
Lamine.
things. Intestinal nephritis. And we know Dr. Babale would have even gone to town. I don't need to be asking. So we know what to look out for. GI bleeding, the risk of Reyes syndrome in children. We have talked about that. So somebody, having influenza, varicella, you don't want to give them what's it called, aspirin. So give them acetaminophen because you don't want to trigger Reyes syndrome, which is dangerous. So now, this is where USMLE will now wait for you. So they will tell you. Arrow question. They like arrow question like mad. Arrow question. So what is going to be the toxic manifestation of aspirin overdose? In the early stage, the first thing you are going to see is respiratory alkalosis. Why? Aspirin is also known as N-acetyl salicylic acid, right? It is an acid.
Yes.
So salicylic acid. So what do you think the body will do when you inhale, when you take in acid? The body will want to do a respiratory compensation, right? Because you have ingested an acid. That's metabolic. Your respiratory pathway will compensate for it. So the body will start hyperventilating so that they can take out more CO2, which is an acid, to reduce the acidic content. And when an individual hyperventilates, what do you think will happen to the level of CO2 in the blood?
It will decrease.
It will decrease. So that is going to,
Reduces
yeah. So that causes what? Respiratory what?
alkalosis.
Alkalosis.
Now, later, Dr. Babarinde must have, okay, we have not done biochemistry, right? Have we done biochemistry? No.
No.
So,
Not yet.
so we are going to talk about the oxidative phosphorylation pathway, and it's going to tell us what we mean by the uncoupling mechanism. You see, the oxidative phosphorylation pathway is a pathway by which oxygen helps us to produce ATP. I'm not going into details right now. I'm just giving you a background. So if we are using oxygen to generate ATP, it is through the oxidative phosphorylation pathway. It is an important pathway we need to know. So now there's something we call uncoupling. Uncoupling means that you cannot link oxygen transfer to ATP generation again. And one of the drugs that can cause uncoupling is aspirin. If you give aspirin, aspirin will uncouple the oxidative phosphorylation pathway, and you cannot use oxygen to oxidize in order to phosphorylate ADP to ATP. Very simple. Oxidative phosphorylation. You cannot use oxygen transfer to phosphorylate ADP to ATP. So that means that you cannot generate energy anymore. So what do you think the body will resort to? The body will shift from the aerobic pathway to the what? Anaerobic
Anaerobic.
pathway. And if the body shifts to anaerobic pathway, what do you think is the product of anaerobic pathway?
Lactic acidosis.
Lactic acidosis. So this patient is going to be having metabolic acidosis.
Acidosis.
So at the later stage, what do you think this person is going to be presenting with? A mixed metabolic acidosis and a respiratory alkalosis. That makes sense. That makes sense. So that is it. Uncoupling of the oxidative phosphorylative chain. So how do you treat aspirin overdose? Just give like a base to neutralize it, which is what? Sodium bicarbonate. Very simple. Very, very simple. So moving on to celecoxib. We have talked about this. This guy is a selective COX-2 inhibitor, and it reduces the production of PGI2. We have said it that PGI2 is very helpful in what's it called? In preventing platelet aggregation, and at the same time, it is also important in relaxing the vascular endothelium, right? But there's another additional function of PGI2. It is helpful in inflammation. So it means that if you take out PGI2, there's no inflammation, the vascular endothelium cannot relax, and the platelet will not what's it called? When the platelet will continue aggregating because you are going to activate what's it called? Your thromboxane, and thromboxane will keep activating the platelet. There's going to be platelet aggregation with clot formation. There's going to be vasoconstriction from the action of the thromboxane, and there's going to be no signs of inflammation, right? So, that is what it does. And what's going to be the side effect? Just like what we have here, risk of thrombosis and what? Sulfur allergy, because some of them contain sulfur. So the individual can have sulfur allergy and there's an increased risk of thrombosis. I have explained why there's an increased risk of thrombosis. Who wants to remind us? Why?
Because the pathway will shift to thromboxane.
Exactly. Because the pathway shifts to thromboxane and you have thromboxane activating the platelet, causing vascular constriction, causing increases of thrombosis. So you use it in inflammatory disease like rheumatoid arthritis and also in osteoarthritis. Don't forget, COX-2 is present in inflammatory cells to produce PGI2, which helps to drive inflammation. So that means that if you drop PGI2, there's less inflammation. So you can use it to treat inflammatory disease. But don't forget the risk of thrombosis. So don't give it to people with risk of MI, risk of stroke. Moving on to the other non-steroidal anti-inflammatory drugs. So I said that why these ones are separated, the ibuprofen, naproxen, ketorolac, I know we know all these things. So why they are separated is because they do not irreversibly inhibit COX-1 and 2. They do it reversibly. So they have antipyretic action, analgesic action, and anti-inflammatory action. But they don't have anti-what action? Anybody remembers? Which action do they lack? Which action of aspirin do they lack?
Antiplatelets.
Antiplatelet activity. They don't have antiplatelet activity. Very important stuff. Now, just like aspirin, if you give it less than 300, you can use it to take care of platelets. I'm just recapping aspirin. If you give it 300 to 2004, you can use it for antipyretic, analgesic action. If you give it 2004 to 4000, you can use it as anti-inflammatory. So these other NSAIDs, they have anti-inflammatory action, they have analgesic action, they have antipyretic action, but they don't have antiplatelet action. Some of them have specific uses. I'm sure we have done cardio. The drug of choice to close a PDA is what? Indomethacin. Everybody knows this. We have talked about the side effect. It's very similar to that of aspirin. Interstitial nephritis is there. Gastric ulcer is there. Renal ischemia is there. We have explained it. And they can also cause aplastic anemia. They can cause aplastic anemia. Please, we know the difference between aplastic crisis and aplastic anemia now. Abi?
Yes.
Okay. So,
Yes.
leflunomide. So, this is one of those drugs that helps to reduce inflammation too. And it basically works by inhibiting the pathway of the pyrimidine synthesis. So this might not really make much sense to us now because we have not done biochemistry. But trust me, this drug will be re-emphasized again in biochemistry because it's in the pathway. So we'll know it again there. So it reversibly inhibits the hydroorotate dehydrogenase. So Dr. Barinde is going to mention it again. And you cannot form pyridine in the process, and you cannot form your T cells because your T cells are dependent on your pyrimidine for their own proliferation. So T cells will stop, being formed. And you can use it to reduce inflammation in like rheumatoid arthritis and psoriatic arthritis. Can anybody guess? Okay, let me just say it. So the reason why we are using it in DMARD and psoriatic arthritis is because leflunomide is part of the what? The DMARD. So it's one of those drugs you use in treating rheumatoid arthritis specifically. So leflunomide is one of them. Just like methotrexate, sulfasalazine, leflunomide is one. And if we are using leflunomide in psoriatic arthritis, I've mentioned it, right? Okay, I've said it, that psoriatic arthritis requires DMARD. Hope we remember when I mentioned it.
Yes.
It requires
Yes.
DMARD. So that is not the time we are giving vitamin A or vitamin D derivative. You actually give DMARD if a patient is having psoriatic arthritis. So it's hepatotoxic, it's teratogenic. It's not usually well tested, but you can know that. Biphosphonate, alendronate, all those dronates, ibadronate, resdronate, zoledronate, pamidronate, all of them. they have biphosphonate. Biphosphonate is a very good guy, until when it starts causing side effects. That's when it becomes bad. But it's a very good drug. It's helpful. It contains pyrophosphate analog, and this pyrophosphate can, bind to hydroxyapatite in bone. Of course, we have hydroxyapatite in all our bone. So they have sites for anything that has pyrophosphate structure to bind to. And biphosphonate has pyrophosphate structure. So it can bind to the hydroxyapatite in bone. And what does it do when it binds to this hydroxyapatite? We have to know clearly what it does. What it does is to inhibit osteoclastic activity. Osteoclastic activity is there to break down the bone. So it means that if it inhibits the osteoclast, you can no longer resorb and break down the bone. And what will happen to the level of calcium? So level of calcium is going to come down, right? Do we agree with me?
Yes.
Yes.
So what are the clinical uses? You can use it in osteoporosis. Why? Because people with osteoporosis already have, weak bones. So you don't want to be increasing the breaking down of the bone by the osteoclast. So suppress the osteoclastic activity to treat osteoporosis. You can use it in hypercalcemia. We have already talked about this, that in hypercalcemia, calcium is elevated. So prevent further osteoclastic destruction of the bone to release calcium. So if you stop that, the bone is not being destroyed again, calcium is not being released. So there's nothing affecting there is a moderation of the calcium level. So to treat hypercalcemia. That makes sense. So although it's not the first line for hypercalcemia, I don't know if we get to Rena. I think Dr. Babande would. Is it Rena? Okay, no. I don't think we have to worry about treatment of hypercalcemia. Step one, don't worry. But know that biphosphonate can be used. The next is Paget disease of the bone. Paget disease of the bone. Have we done MSS?
Yes.
Yes.
So
Yes.
Yes.
so that means we can go to town with Paget disease of the bone. We know everything about Paget disease of the bone. So there's a phase in which you have osteoblasts, right? And there's a phase in which you have osteoclastic activity, right?
Yeah.
So there's
Yes.
bone remodeling, blah blah. So you want to suppress the osteoclastic activity by giving your biphosphonate. Paget disease of the bone. Metastatic bone disease too, same thing. There can be bone resorption when there is metastasis to the bone. So suppress osteoclastic activity, prevent the bone resorption. Osteogenic imperfecta, there's weak, brittle bones. Suppress osteoclastic activity so that you don't further damage those weak bones. So, biphosphonate. What is clinically relevant to our exam is not more of the clinical use of biphosphonate, but the adverse effect. We have to be familiar with the way it works and its adverse effect. Those are the two important things. Number one is esophagitis. So you just notice that people that have taken biphosphonate develop what we call pill esophagitis, and you start seeing like constrictive rings, in the esophagus, causing dysphagia, and they usually contain eosinophils. So that's like eosinophilic esophagitis in a way from the pills. So it causes dysphagia, and we try to avoid that by telling the patient to stand up, take water while they are using this drug. You don't take biphosphonate and lie down immediately. You are not doing yourself, and because the transit time of the drug through the esophagus will be delayed. So stand up, take it, use water, stand up for a while before sitting down. Don't just take it and lie down because you are playing with esophagitis. The second is osteonecrosis of the jaw. So this has been believed to be due to problem replacing the oat bone. So osteonecrosis of the jaw and atypical femoral stress fracture, both of them have been linked to problem replacing the oat bone. Let me give an example of what I'm talking about. If we want to synthesize a new bone, we need to break down the old bone. Does that make sense to us? Like, you want to produce a new bone and you want to do the process of remodeling, break down the old bone so you can lay down new bone by osteoblast. But because an individual is on biphosphonate, they cannot achieve that because biphosphonate will not even allow you to break down your whole bone. It will have inhibited all the osteoblast, and your osteoblast will never break down the bone. It will rather form new ones. So that makes the bone very weak, and they are susceptible to having osteonecrosis as well as a femoral stress fracture. We call it atypical because you can be seeing it in someone that is as young as 20 years. That doesn't make any sense. Femoral stress fracture should be in people that are old, right? So atypical femoral stress fracture, osteonecrosis of the jaw, very, very important stuff, and esophagitis. You must not forget these three. What is the solution to the problem of biphosphonate? We have to give PTH analog, and that is where teriparatide comes in. So, teriparatide is a recombinant PTH analog, and this guy will work similarly as biphosphonate without inhibiting osteoclastic activity, but rather is going to promote osteoblastic activity. But how do you achieve this? You have to be smart about the way you give your teriparatide. You give your teriparatide in a pulsatile fashion. I know that Dr. Babarinde must have explained it, that if you give PTH analog continuously, you are going to be, stimulating osteoclast. If you give it pulsatile, you are going to be stimulating osteoblast. Do we remember him saying that?
Yes.
Very
Yes.
important.
Can you take that again, please?
So, in order to facilitate osteoblastic activity from use of teriparatide, which is a PTH analog, you need to administer the drug in a pulsatile fashion. If you give it continuously, it's going to stimulate osteoclast and there's going to be bone breakdown. Do you understand that?
Yes, thank you.
So, what do you use that for? Osteoporosis, so that you can stimulate the osteoblast, you will lay down new bones that are better and reduce the chance of, the pathologic fractures. So it causes increased bone growth compared to, anti-resorptive therapy like biphosphonate. So we can prefer these to biphosphonate, right? So, yeah. So it can cause transient hypercalcemia because remember, PTH reabsorb calcium from the intestine, from the kidneys, everywhere. So they can be transient hypercalcemia. So moving on to gout. So the first are the chronic gout drugs to prevent gout. And what's the first on our list? Allopurinol is very common. And allopurinol is a xanthine oxidase inhibitor. When we start BTH, we are going to talk more about this. And what does it mean? It means it is a competitive inhibitor of metabolism of hypoxanthine and xanthine to urate. So xanthine oxidase is an enzyme that converts hypoxanthine and xanthine to urate. So allopurinol is going to prevent that, to prevent gout. Why? Because if you prevent conversion of hypoxanthine and xanthine to urate, you have less urate. So you have less urate depositing in the joint to cause gout. So it's preventive. We also use it in people with, high risk of cell turnover, like from malignancy, like lymphoma, leukemia. They can, when the cell lies, they release a lot of urate, potassium, phosphorus, everything. And to prevent, urate nephropathy from the tumor lysis, from lymphoma and leukemia. If you are treating a patient with lymphoma and leukemia, you want to give them allopurinol to prevent urate nephropathy. But what is the side effect of this allopurinol? Aside the fact that it can trigger all these Steven Johnson, all these dress syndrome, and all those things that we have talked about, you also want to be careful with combining allopurinol with a particular drug called azathioprine and its prodrug, which is 6-mercaptopurine. This is going to be emphasized in biochemistry as well, because azathioprine and 6-mercaptopurine, they are degraded by xanthine oxidase. Now, if you inhibit xanthine oxidase, What do you think will happen to the level of azathioprine and 6-methylcopyrin? Anybody?
To increase.
It
To
would
go up.
To increase.
increase.
And azathioprine and 6-methylcopyrin, they are immunosuppressants. So they would fight the T cell, the B cell, they will shut them up, and the individual will become immunosuppressed. And what will happen? Myelosuppression, and the person will be predisposed to infection. So you have to be careful combining allopurinol with azathioprine or 6-methylcopyrin, commonly tested stuff. The next is pegloticase, rasburicase, pegloticase. All of them, they are recombinant uricase activity, and they catalyze uric acid to allantoin. Allantoin is a more water-soluble form of uric acid, which can be excreted in the kidneys. That's it. The next is febuxostat. Just works similar like allopurinol, the same mechanism, inhibits xanthine oxidase. Then the last is probenecid. So you have to be careful giving probenecid people with penicillin, because it will prevent the penicillin from being secreted. It prevents penicillin from being secreted, and it can cause penicillin toxicity, right? It also inhibits reabsorption of uric acid in the proximal tubule. So it means that you are going to be having a loss of uric acid in the tubule, reducing the what's it called, the uric acid load. Now this is good, because if you reduce uric acid load, you have a less chance of actually developing gout. It prevents tubular reabsorption of uric acid in the PCT. That's probenecid. That's what it does. So now I want to state something here, that probenecid and high-dose salicylate, they work the same way. They work the same way. High-dose salicylate, high-dose aspirin, and probenecid, they work the same way, because they both inhibit reabsorption of uric acid in the PCT. But diuretics and low-dose salicylate, they work the same way, which is that they prevent tubular secretion of uric acid. Now, if you forget what I've said, this is what I usually do. Probenecid and diuretics. Probenecid is longer than diuretics in terms of letters. So that means that high dose salicylate stays with probenecid, and low dose salicylate will stay with diuretics, because diuretics has limited letters, right? And the diuretics we are talking about here specifically are the thiazides. The thiazide cause hyperuricemia. Hope we know this. We know this, right?
Yeah.
So,
Yes.
Yeah,
Yes.
yeah, gluc. Is it gluc? What's the acronym again? Gluc or something?
Hyperglycemia.
Hyperglock.
Yeah.
Hypergluc. Now, if somebody's on thiazide, it means they are predisposed to having hyperuricemia, right? And that is due to the fact that it inhibits the kidneys from secreting uric acid into the tubular lumen. And we have said it that the one with the smaller letters takes the low dose. The one with the highest letter takes the high dose. So probenecids have more letters, so it works similarly as high dose salicylate. While diuretics have less letters, it works with low dose salicylate. So that means that low dose salicylate prevents secretion of uric acid, while high dose salicylate prevent reabsorption of uric acid. That is the way it works. So that's the way, I quickly merge all those things together. Now, moving on. So those are the drugs for chronic gout prevention: allopurinol, febuxostat, pegloticase, and or rasburicase. All of them, they just convert your uric acid to allantoin so that you can excrete it. Then probenecid, which is the one that will prevent reabsorption of your uric acid so that you can lose everything in urine. Now, a patient comes to you.
Doc, please, can you take that explanation again when you were talking about low dose salicylates and the high dose salicylates, please?
Okay. High dose salicylate belongs to probenecid, long letters. Low dose salicylate works with diuretics, short letters. Do you first understand that? That is the basic stuff. Do you first get that?
Yeah.
Okay. And with I said diuretics like thiazide, they cause hyperuricemia because they prevent secretion of uric acid into the tubular lumen. So if you are not secreting uric acid into the lumen, it means uric acid is going to stay in the blood and there's going to be hyperuricemia. And I've already said it that diuretics and low dose aspirin, they work together. So that means that low dose aspirin will what? Prevent secretion of what? Uric acid in the blood, in the kidneys. Do you understand? Hello?
Yeah.
So that's what I'm saying. So low dose salicylate and diuretics, they do the same thing. They both prevent secretion of uric acid into the tubular lumen. So when that is prevented, you have a lot of uric acid persisting in the blood, causing hyperuricemia. Why the opposite is probenecid. Probenecid and high dose salicylate, they do the same thing. They prevent tubular reabsorption, not tubular secretion now. They prevent tubular reabsorption, limiting the amount of uric acid in the blood, increasing the amount of uric acid that is excreted in the urine. Do you understand?
Yeah.
Now, I'm
Thank
going to ask a question now to be sure that we understand what I'm talking about. Let me proceed. A patient comes to us presenting with acute gouty flare. The first line is to give any NSAID, ibuprofen, aspirin, anything you want to give it. But you must be cautious with the use of salicylate. Now, if you want to give a patient with acute gout salicylate, which dose of salicylate are you going to offer that patient? Anybody?
High dose salicylate.
High
High
dose
dose.
salicylate. Fantastic job. You are going to give that patient high dose salicylate. So that is why they have this clause here that use salicylate with caution may decrease uric acid excretion, particularly if you give it at low dose. So if you don't remember, quickly use this diuretic probenecid algorithm and just figure it out. So if you are not giving NSAID, you can give glucocorticoid. Give it orally, give it parentally, or intra-articularly. The last is colchicine. So all these three drugs, you use it in acute flare. Don't ever forget it. Don't ever forget it. Acute flare. NSAID, glucocorticoid, or colchicine. You don't use colchicine when it's more than 48 hours. That's step 2 stuff, though. I'm not sure they will ask that. So, but just for your information, once it's more than 48 hours, just don't give colchicine again. The way colchicine works, they can ask you. It binds and it stabilizes tubulin. That's what it does to inhibit microtubule polymerization. It binds to the tubulin. Tubulin is one of the integral components of microtubules. When you cannot polymerize your microtubules, there's no way your neutrophils can move again. So there's no neutrophilic chemotaxis, there's no degranulation, and you reduce the inflammatory response in the gout. So colchicine can cause GI manifestation. They ask that. They can ask you that. You have to know that. It can cause GI manifestation, diarrhea, and all those things. It can also cause myelosuppression and nephrotoxicity. Yeah. Don't forget about the drugs to treat what's it called chronic gout. Now, moving on to the TNF alpha inhibitors. So we have to listen carefully here. This might sound a little bit complex, but it's not complex. You have two classes. Etanercept is a class. Adalimumab and infliximab, they are monoclonal antibody against TNF alpha. So these ones are monoclonal antibody, right? Etanercept is a fusion protein. So what are we talking about here? So what we are talking about is that etanercept is a drug that has receptor for TNF alpha coupled to the Fc region of IgG antibody. Let me tell you what they are saying. It means you have a receptor for TNF just attached to IgG. That's what they are saying, attached to an immunoglobulin. And the reason why they are doing that is that they want to prolong the half-life of that drug. Now, we call etanercept a decoy receptor. What do we mean? It means that once you give a patient etanercept, because of the fact that it has receptor for TNF alpha, all the TNF alpha in the body are going to be deceived and they are going to be binding to etanercept instead of binding to their own real innate receptor. So it means that you are not going to have any TNF alpha activity and there's going to be reduced inflammation. Does that make sense to us? Anybody? Does it make sense to us?
Yes.
No, please can you
Can you
repeat?
come in?
Yes.
Please.
Okay. So TNF alpha is a drug that contains, sorry, etanercept is a drug that contains TNF alpha receptor coupled to IgG. Do we understand that? Now, when you give somebody etanercept, all the naturally circulating TNF, which is a cytokine, they are going to be binding to etanercept because we have said it that etanercept has TNF alpha receptor. Do we understand? And if the TNF are binding to etanercept, it means that they cannot bind to their own innate receptor in the tissues. And when they cannot bind to the tissues, to the cells, macrophages, they cannot achieve inflammation. Do you understand? So that is an anti-inflammatory effect of etanercept. Do we get it?
Yes.
I'm not hearing
Yes.
anybody. People that said
Yes.
no, is it clear to us now? Hmm?
Yes.
Okay, that's good. So you can use it in all those DMARD, blah blah, everything. Then the other ones are straightforward, the monoclonal antibody. They just go and bind to TNF alpha and neutralize it. That is it. Adalimumab and infliximab. Now they can give you this stuff in your exam that this patient is having rheumatoid arthritis or having ankylosing, whatever, and they are placing him on etanercept, adalimumab. What is going to be the side effect? This is where you are going to come for them because you already know that if you give somebody TNF alpha, okay, we have not talked about it. We have to talk about it in pathology. TNF is one of the cytokines that help to form granuloma to be able to confine tuberculosis in a space. It means that if you inhibit TNF, you cannot form granuloma. What do we think will happen to the tuberculosis if granuloma cannot be formed? Anybody?
The reactivation.
Discrimination.
Tuberculosis will just reactivate and be
Yeah, we
fighting and be causing problem. So that is why before you commence anybody on a TNF alpha inhibitor, you have to do a test for tuberculosis. That is what they want to test in your USMLE. As simple as it is, it can be tested. You also have to watch out for the risk of drug-induced lupus, although there are so many drugs that can cause drug-induced lupus. Now, what are the other psoriatic biologics? Utekinumab, interleukin 12 and 23, secukinumab, interleukin 17. I think those are the only ones that we need to know. It's unlikely you are going to be tested on this. Imiquimab is a drug that is useful in the treatment of actinic keratosis. We remember what I said about actinic keratosis, as well as what?
It's pre-malignant.
Pre-malignant for basal cell carcinoma,
Squamous
Squamous
cell.
cell.
for squamous cell carcinoma. So imiquimab binds to toll-like receptor 7, which you find on the macrophage, the monocytes, all these things, activate them. And from there, you can, start activating your T cells, your B cells. That's why you call it immune response modifier, so that you can start destroying tumors. So it kind of sensitizes the T cells, the B cells to tumors or potential, pre-malignant lesion and take care of them. So like what? Like actinic keratosis. So that's imiquimab. See imiquimab, what comes to mind? Particularly to me, imiquimab, I remember what? Imiquimab, what? Imiquimab, what? Because it activates toll-like receptor 7, which is found on the macrophage. And when the macrophage, the dendritic cells are activated, you activate your T cells, and from there, they will start, attacking all the potential cells like the warts and the actinic keratosis, taking care of them completely. So with that, on that note, we have come to the end of dermatology. So Do you have any question?
Dr. Babali, the biologics, I don't know if it's a new addition